Great. So first, kind of getting oriented. The orientation of the screen is really dependent on how your equipment is set up. You can actually flip the orientation so the vocal folds are kind of facing up and not down. But this is probably more standard, especially I think in the United States, to have this orientation where the vocal folds, the V is kind of down, but in other, you can switch the computer so that the V goes up. That would totally mess me up, I think, and disorient me. But this is how most of our images look most of the time. But again, it's kind of clinician and equipment specific. So in this example, we have that axial view. It's kind of a bird's eye view where we're looking down onto the pharynx like this. And so as we kind of go down, we're going inferior. As it's coming up towards us, it's coming superior. The image looks like it's kind of flipped. So this is actually the left side, and then this is the right side. And then this is anterior, and then this is posterior. And so I think as you're starting to get used to fees, and as we're starting to kind of start to describe anatomic abnormalities and what we're seeing, residue, and all these other findings, we want to start to use these types of directionality terminology to be a lot more specific. So if we use this as kind of a reference, this generally, and we're going to get more specific, is the base of tongue. This is generally our vallecular space. This is the glossoepiglottic fold. If we want to be specific, we'd say the median glossoepiglottic fold. Laterally, and maybe there is a slight difference, but I see this kind of interchange between lateral glossoepiglottic folds and pharyngoepiglottic folds. Maybe they're used interchangeably. Maybe I need to do a little bit more research, and maybe like this is glossoepiglottic and maybe this is pharyngoepiglottic. Like maybe there's two different folds in there that I'm not aware of. But otherwise they're used pretty interchangeably. And the idea, we're not doing surgery on these people. We don't need the exact muscle, but like this is the structure that we're talking about right here. These are the piriforms. I recently saw on social media someone ask a question, are there left and right piriforms, or is it one piriform with two different sides, kind of like the vallecula? And I don't have the answer to that. I think it makes sense as the post-cricoid region comes forward that it does look like it is kind of one continuous like kidney bean shape type of shape. But when you go to other kind of authority figures like head and neck cancer staging, they do actually say left and right piriform. And so there are some anatomic references that do separate it. And certainly we separated it here, but I didn't actually give it that much thought. But maybe you could think of it as one continuous piriform as well. I'm not sure it makes a huge difference, to be honest. So this region I would call the post-cricoid region, and then that slit right back there I would specifically call the UES inlet, right? And so that's the inlet into the upper esophageal sphincter. It's that muscle that's tight at rest, and then when we swallow, it should open up, stuff dumps down, and then it closes right back up. This area where we start to see a slight change in color and kind of texture of the tissue is the what we call the intra-arytenoid tissue. We have our arytenoids. We could get some better images on here that I would use for teaching, but the arytenoids are pyramid-shaped structures, right? And so right now where the arrows are pointing is really kind of the superior most aspect of the arytenoids, but the arytenoids actually extend inferiorly and posteriorly. So it's like this huge triangle, and then this is just the top of that pyramid. So actually the anterior inferior part of the arytenoids is this area right here, the vocal fold process. And so that's where the membranous part of the vocal fold connects to the arytenoids. Then when the arytenoids move, the vocal folds also move as a result. They also extend posteriorly and inferiorly. And so this would be the cartilaginous portion of the vocal folds kind of attaching to that portion of the arytenoids as well. We have the epiglottic folds, which is the fold of tissue that connects the arytenoids to the epiglottis. It's mostly just connective tissue, but there are some muscle fibers in there as well, which may help with things like arytenoid epiglottic contact. So if we were talking about residue on the lateral edge of the epiglottic folds, we move moving out laterally. And if we said medial, it means that we're going midline. We're going towards the middle of the screen. We have our epiglottis. The epiglottis is a long structure. which extends down into here and ultimately into the thyroid cartilage, which we don't see on this image. Colloquially, when we just talk about the epiglottis, we're probably talking about the free end or the floppy part of the epiglottis, so the part that kind of pushes horizontally and vertically during swallowing. But technically, it's actually a much longer structure that inserts into the thyroid cartilage. Part of the epiglottis is its base. And so this is what we call the epiglottic petiole, which is foot or base or something to that in Greek. I'm not quite sure because I don't speak Greek. But this is the base. And so that little bump that we see within the laryngeal vestibule is technically actually part of the epiglottis. We have our ventricular folds, which are those folds of tissue right there, also called the false vocal folds, also called the vestibular folds. There's a space between the vocal folds and the ventricular folds called the laryngeal ventricles. So ventricle just means space. That's what that is. And we don't get a great appreciation of it on endoscopy or fluoroscopy. Surgeons get a good view of it. So it's a space that's in between the false vocal folds and between the true vocal folds and the false vocal folds, or the vocal folds and the ventricular folds. And it's a space that actually kind of curves up superiorly and laterally. And so we don't see that here, but like the ventricles are probably kind of all the way up here, just like inside the tissue right now. Again, that's important to know because there's lots of secretion globulate cells that make secretions that help to lubricate the larynx that are in there. Because of that, sometimes secretions are oftentimes on the vocal folds that we see. It's possible that residue can sometimes get stuck up in there and then show up a couple swallows later because it was stuck in that little pocket. We have the vocal folds themselves. You'll see us talk about this later when we talk about anatomic boundaries, but we can separate the vocal folds into thirds, essentially. This is not done so much in the swallowing world. It's done a little bit more in the voice world, especially as we interpret stroboscopy. But the anterior 2/3 is this membranous portion. It extends from here, the anterior commissure, to the vocal fold processes, right? Those little white kind of knuckles. So that's the anterior 2/3, and the posterior third is this cartilaginous portion. It's a non-vibratory portion. We don't really give it too much mind in the voice world, to be honest. As speech pathologists, certainly things like lesions and cancers and stuff can certainly develop there, but from a vibratory parameter standpoint, it's not really influencing us that much. So this would be the anterior 2/3. This would be the posterior third. So if we talked about like something being right there, whether it was secretions or residue or the appearance of some sort of benign vocal fold lesion, we might say it's at the mid-membranous portion of the vocal folds because it's the middle part of the membranous portion. That's also called the striking zone, and I think it has another name as well. The junction between the anterior and middle 1/3 is the other way you could say it. Okay, so then we have our subglottis, and within the subglottis, we have the subglottic shelf, which is this little triangle right here. The triangle goes up to that first ridge, which is typically the cricoid cartilage. I think sometimes it's the trachea, but I believe most of the time it's the cricoid cartilage. And then lower down, we have the trachea. Okay, so that's just kind of a general understanding of our anatomic boundaries. Okay, so then let's get into kind of the main, like the 4 rules or parameters. I hate saying rules. I need to think of a better term. But the construct, well, one of the constructs of VASES, I don't know, whatever. Okay, so the where. So the where of VASES refers to the anatomic boundaries that are defined by VASES. These are meant to align with actual anatomy, but we are standardizing it as we see on endoscopy to improve the transparency and reliability of our terminology use. So there are 6 structures, or probably better worded as regions, that we outline in VASES. These include the oropharynx, hypopharynx, epiglottis, laryngeal vestibule, vocal folds, and subglottis. So each of these has like physiologic meaning associated with it, right? Especially when we start to think about swallowing perspectives. There's different muscular structures in each of these regions. They have different impact on swallowing safety and efficiency, and there's probably different reasons that lead to residue in these different areas. And so we use these 6 anatomic regions or structures to help facilitate our transparent and standardized and hopefully more reliable ratings of pharyngeal residue, penetration, and aspiration, as well as things like bolus location at swallow onset. I'll say with VASES, we use the term residue to not just mean pharyngeal residue, but it could be residue within the airway and subglottis, which is part of the airway. So we can have penetrant residue, aspirate residue. Residue just refers to anything that's left behind after the swallow, and it could be anywhere. And I think as speech pathologists, we hear residue and we assume pharynx, but it's not just about the pharynx. Okay, so let's get into how we draw these boundaries, separating these different structures. So if we want to kind of identify the oropharynx and hypopharynx, we need to think about the boundary that separates these. So to do this, what we're doing is we're identifying the 2 points where the epiglottic folds merge into the epiglottis, right? We're doing this to the best of our ability. We are not AI. This is not completely objective. It's perceptual, and so there's some inaccuracy and imprecision that's with that, and that's fine. So we don't need to stress out if you're calibrating with your colleagues that you're not getting the exact same pixel and not agreeing exactly. Because it's kind of a continuous thing ultimately too. So we might just kind of be placing weights in slightly different things. But the idea is that we're trying to get much more specific when possible. So if we go back to this, we're trying to see where do the epiglottic folds merge into the epiglottis. Conceptually, you're thinking, where does that tissue of one merge in the other? And you can't really tell where does the one start and the other stop. Like what is that? So one tip, depending on kind of your camera and light source, is you might be able to kind of follow this black shadow line. I'm going to go back one more. And then you could look for the point where it essentially trifurcates, where it becomes like a Y or a T or something like that. That's probably the point. But conceptually, you're thinking, oh, like here, I see like a ridge. Like here's the epiglottic fold, and this is the epiglottis. So it's like, oh, this point right here is where they seem to kind of like morph into each other, essentially. So once we find those 2 points, you would draw an imaginary line across the screen. And everything above that plane and or anterior to that plane would be the oropharynx, right? And a slight exception would be that the vallecula is embedded within the oropharynx, and that technically that's kind of like inferior to that line, but it's at least anterior, right? And so this this should align almost exactly with actual anatomic definitions of what the oropharynx is. Like when we go to head and neck cancer staging systems, relatively specific in some of these definitions if you look at these online sources which help to stage head and neck cancer, but most of them say that the oropharynx aligns with the hyoid at the level of the hyoid, and anything superior with the vallecula embedded within that. And so this region right here where the epiglottic folds are merging the epiglottis seems to almost always align with that. I'll say even with head and neck cancer staging, there's a bit of inconsistency. So they'll say some definitions, but then the pictures will be like the top of the epiglottis, but like that's not the level of the hyoid. So there's a little bit of inconsistency here, but regardless, this does seem to align with what's described in other areas and other fields. So hopefully this is a good thing in case people are wondering about this. And so this is what the oropharynx is intended to capture, right? In the original publication, we didn't have these little triangles here, and we should have, right? So we should think that the pharynx is the cylinder that we're looking down in. So we have this plane, and we're trying to think about this plane up, right? And so I think like if we extended this line all the way over, it would be probably at around this level. And so it'd be capturing this mucosa. maybe I'm not 100% right. I might think I'm pretty close to being right, but there's some error that's in there, right? And so that's kind of just at least what we're conceptualizing. That's the intent of this. Within the oropharynx, we have the vallecula. And so the vallecula is defined as a pocket that's contained within the oropharynx. It's bounded anteriorly by the base of tongue. It's bounded posteriorly by the rim of the epiglottis, and it's bounded laterally by the lateral glossoepiglottic folds or pharyngoepiglottic folds, but like the medial most portion of those folds, so like right here. Notably, I think we have it here, we define the rim of the epiglottis on VASES as the point where the laryngeal and lingual surfaces meet. So that's kind of what this line is supposed to represent. There were other clinicians and researchers who define the rim of the epiglottis slightly different, where maybe it's like the highest point of the epiglottis, or I don't know, sometimes there's not definitions, there's just pictures and it looks like it's a little bit lower down. And so the rim of the epiglottis, that's a term that's been used before and has sometimes been defined, sometimes not. And so for transparency, this is how we're defining it. The point where the laryngeal and lingual surfaces conceptually meet. So this is the vallecula, right? The vallecula is contained within the oropharynx. The thing to note is that the vallecula is a space. It's a pocket, right? And so it's going to be changing in terms of how large or big it is. If we ask someone to pull back their tongue, maybe they're saying the word ball, right? They're retracting their tongue. It's probably getting close to hitting the epiglottis. Our vallecular space goes from being this big to being this big, right? If someone is maybe kind of squeezing their pharynx in concentrically right now, the lateral edge is kind of coming in a little bit. And so there's lots of reasons why the size of the space can change. Maybe they've had tongue resection, or they're edematous, or their posture is up versus back or something. And so the size of the vallecula is variable considerably because of the structures around it. And I say that because when we get to rating oropharyngeal residue, we rate it relative to the vallecula. So we think about how much residue do we see anywhere in the oropharynx, so anywhere in this blue shaded region. We would put it all into the vallecular space, and we ask ourselves, how filled is the vallecula with oropharyngeal residue? And so to do that, we need to standardize the housing space size, the size of the vallecula. And so to do that, we think about the person's anatomy, right? It might change from person to person, but using the person that we're seeing at hand, when their vallecula is at its largest, kind of at rest. So they're not doing some crazy kind of behavior, but maybe a slight chin up posture, breathing situation, right? So that's kind of what we're thinking about normalizing in our head, what their vallecular space is. We might not get that image during the actual swallowing protocol, so we'd have to go back to thinking about this beforehand. And I think this goes to highlight why we spend a little bit of time before giving them food and liquid to really get used to their anatomy, so we can start to use these as a reference moving forward in our interpretation. Questions about that? I'm going to take a sip of coffee. I'm going to close that vallecular space. I'm going to open it right back up.
Hey, James.
Yeah.
Can you point out with your cursor again for the where the laryngeal surface meets the epiglottic rim for your definition?
Here, like right where this blue thing is.
And what are you saying for the laryngeal surface? Just anything beyond that point?
Yeah. So like right here, I would say is the rim of the epiglottis. Why I forgot that word. And so the lingual surface would be like the underside, you can think about it, the side that's now facing the tongue, and the laryngeal surface would be the opposite side, the side facing the pharyngeal wall and or the larynx. So essentially the side that would hug over the larynx when it got retroflexed during swallowing. Yeah, great question. So like even here, like if we like stare at the epiglottis and cross our eyes, like I have here on the one image, but like, I don't know, maybe it's actually there. Okay, this is perceptual. It's subject like, and so this is where some of the subjectivity is going to kind of come in, right? But like we have a standardized definition and we're trying to get as close to that as possible. But this is intra and inter-rater reliability, which is what we're trying to improve with VASES. Okay. And I say that not to say that VASES is amazing and also not to say that VASES is terrible, right? Every method that we use for assessment in clinical and research practices has benefits and limitations. And we're always striving to make these methods more reliable and more valid. And so it's important to know, like we have these definitions, they sound really transparent with VASES, and they are pretty transparent, but it's still perceptual. So we're still never going to be 100% reliable. Yeah, so just kind of keep that in mind. But hopefully we've gone from being very much not reliable to being much more reliable. So that's hopefully the strive forward that we've made with VASES. All right, we go to the other side of the line, right? So now we go posterior and or, inferior and or posterior, right? So we've got our cylinder, we're no longer up here, now we're down here or posterior. And so this is what we call the hypopharynx. And I do think maybe prior to VASES, we probably didn't use the words hypopharynx and oropharynx that much in swallowing, maybe a little bit more in video fluoroscopy. But even then, I think we would just say like the pharynx, and then we talk about follicular and piriforms. So these are terms that maybe you won't have seen that much in like speech pathology swallowing literature, but they are certainly terms that are real and have been around. Like if we think again about head and neck cancer staging. Okay, so this would be the hypopharynx, the kind of lower down pharynx. Sometimes this is called laryngopharynx in some of our other textbooks and literature, but VASES we're calling it hypopharynx. Embedded within the hypopharynx, we have the piriform sinuses. And so this is essentially thinking about our epiglottic folds, that medial most aspect of the superior portion of the epiglottic folds. And then we go straight across horizontally. We're not up at an angle or going down, but straight across is what we're trying to conceive of, to the pharyngeal wall. Now, the epiglottic folds have this slant to them, right? And so it's going to be horizontal, 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 right? And so there is going to be kind of a vertical change in the piriforms, potentially, depending on their space. But wherever this top portion is, you're just going horizontally straight across. And so essentially we're kind of stuck with like this little U shape on the left and right side, and that has a little bit of an angle to it. And so those are the piriforms, the left and right, which we would kind of separate just by this midline. So maybe it is one continuous one, and we're being arbitrary, but left and right, here we go. So this would again be around the arytenoids, especially when we're thinking about the arytenoids in an abducted position. So if we again reflect back to Voice 101 class, when we think about vocal fold mobility, I mentioned this last week, but for the purpose of this recording, I'll repeat it again. When we have the vocal folds, right? The vocal folds are open like a V when we breathe. They close when you hold your breath sometimes. And then they stay closed and vibrate when we make sound, right? That's how the vocal folds work, like this. I think we typically think about the vocal folds abducting like this, but it's not a two-dimensional opening and closing, it's three-dimensional rotations. So when it abducts, it goes back, up, forward, and back. Sorry, up, back, and out. And as it adducts, it goes down, forward, and in. So up, back, and out, down, forward, and in, up, back, and out, down, forward, and in, right? So that's how the vocal folds move. And so when the vocal folds are adducted, they're going to pull away from the pharyngeal wall and create greater piriform space. But the reason I'm really bringing this up right now is because they rotate down, our concept of what is like the superior border of the arytenoids is going to change if it's adducted versus abducted. So it's really important that we're defining this boundary when the vocal folds are abducted as like what it would look like. And then we go along the kind of the junction between the postcricoid region and the intrarytenoid space. And that region would then be hypopharynx. And then, but the arytenoids and epiglottic folds is what we're using for the, essentially the piriforms. And if there is a huge, you know, gaping space right there, because maybe they're super fibrotic or atrophied or something, then that would be included in part of the piriforms as well. Okay. Questions about hypopharynx or piriform anatomic boundary? I think what's really critical here, and this goes when we start to talk about the laryngeal vestibule too, is that we're not just thinking the middle of the top. We're thinking going as much as towards midline as possible. Where's my mouse? Before we start to go down, right? So that's the boundary that we're using. We're going as much midline as possible before it jumps off the cliff, as much midline as possible before it starts going down. So we're not thinking the top middle, we're not thinking the top middle, we're not thinking the top middle, but like go up. And then when we start to get to that junction, that's the junction that we're using. So just like we did with oral pharynx, when we get to the residue ratings, what you're going to be asking yourself is how filled are the piriforms with hypopharyngeal residue? So to do that, you're thinking about anything in this blue space, putting it all in the piriforms with your imagination, and then thinking about how filled is that three-dimensional piriform space. We don't really care about covering of mucosa for oropharynx or hypopharynx. We're thinking about three-dimensional filling. And just like we do with the oral pharynx, with the piriforms, we have to try to standardize that housing space size, right? Because the vocal folds are abducted, there's very little piriforms. If they're adducted, there's much bigger piriforms. And so if the person can phonate and has vocal fold mobility, then we're judging essentially like during the E. Like if the vocal folds adducted as much as they were capable of adducting, then that's what we're using for a space. If the person has a vocal fold immobility and they can't move it, that's their piriform space. So what is their maximum space essentially during what would be phonation if possible? If they're really edematous and they've got very small piriforms, that's their current space. So we're thinking about their anatomy and their physiology and then using kind of the largest piriform space for them. And that's how we're standardizing it. Questions about that? This is all still technically just the where, and I'm morphing the how as well, but that's okay. Okay, so now we've separated the oral pharynx from the hypopharynx. Now we go into thinking about our epiglottis and vestibule. How do we separate these two structures? So to do this, we'll stick with the same 2 points that we started up with the oropharynx and hypopharynx, which is 2 points where the epiglottic folds merge in the epiglottis. All right, so we look for those same 2 structures. The next step is to find the deepest point, the deepest part of the groove that separates the petiole from the epiglottis, the free end or the laryngeal surface of the epiglottis. So that little groove right there. So typically if you kind of go back, most of the time the epiglottic petiole kind of has this slight like diamond shaped to it almost, right? And so we can think about the groove, follow the groove to the point where it kind of wants to start to go back down, if it has that. If not, then you're just kind of extending it. And then when you can't really see the groove anymore, then just try your best to then connect those 2 points. So go to the end of the groove before it starts to go down, and then connect it. What I want you to really make sure to think about is that we're thinking about not like the middle part of the groove, but like the deepest part of the groove. So sometimes it can kind of be angled in a weird way. You're thinking deepest part of the groove, essentially before we start to go up, like up on the petiole, right? Before we start to climb that little hill if we're a little person in there. So we would connect it, and then that is the kind of inferior boundary of the epiglottis. And then we wrap that line around, around the rim of the epiglottis. to get our boundary for the laryngeal surface of the epiglottis, or simply the epiglottis. Anything on the lingual side would be part of the vallecula, right? So anything on this side is its own laryngeal surface of the epiglottis structure. So for simplicity's sake, we'll just move forward calling this the epiglottis. This would be another vantage point looking at the epiglottis. You can see here, we don't see kind of the tip of the epiglottis anymore. We're seeing maybe 60% of the epiglottis. And so here we have an idea of where the epiglottic folds merge into the epiglottis, there and there. We see this little groove. For me, the groove is easiest to see like in this region right here. And then I'm gonna start to kind of trace it around, trace it up. Can't really see that well here. And then I'm gonna like connect it. And actually it did look like I just did that pretty well. And I wasn't even looking at that second image. So it's like you just kind of follow the method as best as you can, right? So notably, anything on the epiglottis per VASES is not penetration. Not penetration. I've heard some people start to say that per VASES it is. Per VASES it is not. So stuff is in this region, but nothing is lower down, no penetration, okay? Which, if you're used to rating as anything on the epiglottis as penetration, I think some clinicians might start to get a little like, this is going really low. How come you're not considering penetration yet? And I get the kind of like the concern with that. And I think the concern with that is it could go lower, right? And it could start to get to the vocal folds and it slowly get aspirated. If it does, rate it then. But we're not making an inference. Right now, it's just on the epiglottis. And if we go to some of the definitions, especially the definitions used for video fluoroscopy, we're not including the epiglottis in that. It's typically the inlet to the airway, right? It's the laryngeal vestibule, typically. Okay. So that's the boundary for the epiglottis. If we then use this boundary, but instead of going superior and around, if we went inferior and around, then we have the boundary for the vestibule, right? And so essentially we would go back here and we are now thinking about extending this line now for the vestibule. And just like this image, it's not the middle part, the epiglottic fold, it's the towards midline part, right? And so we would be extending this line all the way around, and I'm not going to look at the arytenoids at this point because the arytenoids are adducted, so I don't want to get misguided. So I'd actually look at this in a abducted position, right? So I'm going around, and now I'm thinking about the the superior midline aspect before we start to go down, right? Really kind of at like a vertical level. And so this would then be the boundary for the laryngeal vestibule. The laryngeal vestibule should include this boundary, the medial aspect of the epiglottic folds, medial aspect, but not superior aspect of the arytenoids, and it should include the interarytenoid space. The vocal folds, I tried to black it out here, and the subglottis are obviously not part of the laryngeal vestibule. I already mentioned this, but essentially try to judge, especially the posterior aspects, so the arytenoids and interarytenoid space, judge this border better during abduction, right? I think in the original publication, like I even made that mistake of drawing a boundary here and including like this as the boundary, right? But then actually when the arytenoids go to abduct, they actually kind of rotate up again. And so actually this is more of the superior part of the arytenoids. And so this would be the actual boundary for it. Does that make sense? Why you wouldn't ideally try to make the boundary during adduction? Or how to draw this boundary? Okay. So the laryngeal vestibule is now the first point of penetration, not the epiglottis, but the vestibule. So now if we have stuff in this region, now we're calling it penetration. into the vestibule. And that's that. If we look at this a little bit more, let me get one where it's not. And if we're just looking at the vestibule right now, so don't worry about this boundary. I've put a couple of these into some computers and looked at surface area, and it would appear as though like the medial surfaces of the epiglottic folds and the ventricular folds, so like this little quadrant here seems to account for around 35 to 40% of someone's total vestibule surface area. This is around 35 to 40%. This is closer to around like 15 to 20%. And then the interretinoid space is like 2 to 5%. That's a very rough guide that you can start to use when we start to think about residue ratings. But again, you're going to judge it based off of the person's anatomy, right? And so if it looks like their petiole is huge and these regions are actually kind of small, it might not be 40, 40, 20, and nothing, right? It might be something else. But you can use that as kind of a very rough guide. When we do our residue ratings for the vestibule, we're thinking about how much of the surface area is in contact with residue or is covered with residue, which is different from saying how much of the mucosa do I not see. We don't think about that because sometimes we're using clear water, sometimes we're using really opaque water where we can't see through. So it's just how much of this mucosa is in contact with bolus. Is it 5% of the mucosa, 10%, 20%, 50%? Is all of the vestibule covered with mucosa, with residue? So we're thinking about this blue area here. Okay, the next boundary would be the vocal folds. The vocal folds have several different parts to them. They look pretty straightforward here. They look like little sheets of tissue, but they're very much three-dimensional structures. So essentially, this is the boundary for the vocal folds if we kind of groups everything together. And this is looking at the vocal folds in a little bit more detail now. So this top right image would be kind of the entire boundary of the vocal folds. You can also think about it as the boundary of the glottis. The glottis is technically a space though, which is why we didn't use the term glottis for vases because it refers to space. It's not like an anatomic structure. But this is almost like the level of the vocal folds. Maybe not vocal fold tissue itself, but like the level of the vocal folds. That's how you can think about this. So for this, we included the laryngeal ventricles as part of that level of the vocal folds. Certainly here we're looking at the superior portion of the membranous part of the vocal folds, right? It's superior because it's on top, but then we also have medial edge of the membranous portion of the vocal folds down here. And you can also see this extends on the cartilaginous portion as well. So we have a superior surface of the vocal folds, we have a medial part of the vocal folds, and I think when we do these, we start to, depending on the views that we get, I think it's easy for people to forget that there's like a medial edge, that they've got height to them. It's not just this single two-dimensional sheet, right? And so really kind of keeping that in mind, that there's this medial edge. The level of the vocal folds also includes the tissue between the vocal folds that might not necessarily be the vocal folds themselves, right? And so we're thinking about at the level of the glottis. Is it in the region of where the vocal folds would be closing? So if we kind of go back here in this top left image, we can see the lower part of the vocal fold here and here, like this region right here would still be the vocal folds, even though it doesn't look like it be like a vibratory part of the vocal folds. It's the level of the vocal folds, and that's what we're trying to capture right now. So that would all still be within the level of vocal folds. And yeah, here material between the vocal folds. So here, anything in this blue region in this top right image would be now penetration to the vocal folds, even if it's between. If it's between, it's not aspiration, it's still just penetration to the level of the vocal folds. If it's medial edge and clearly on the vocal folds, still not aspiration, because we're still just at the level of the vocal folds. And I think when we get training in PA in the penetration aspiration scale, we start to think below the, technically it's below the vocal folds, but I think people think below the top part of the vocal folds, and it's not. It has to be below the lowest part of the vocal folds. And I think this is really important for a lot of different reasons. I don't like to make inferences with our objective assessments like these. But if you'll allow me a quick second, like when we start to think about residue patterns, right, what we're trying to capture is when we think about like vocal fold closure, if it's stuck between the vocal folds, it got stuck where the vocal folds were closing, right? So that's not really aspiration. Also, when we think about sensory innervation of the larynx, subglottically, our sensory receptors are innervated by the recurrent laryngeal nerve. And when those sensory receptors are triggered, that's when we get things like cough and throat clear. It's a little bit more complex than that, but I'll just keep it like that. The sensory innervation for the vocal folds and the vestibule is a different nerve. That's the superior laryngeal nerve. And so typically when we think about exciting those nerves from a sensory standpoint, we get a swallow response, right? And so again, it's a little bit more gray than how I made that sound black and white. But if we go with that, then that's important, because now if we're having residue right there and we're calling that aspiration, then we're starting to say everyone has silent aspiration because they're not coughing to that, but they wouldn't be coughing to that because it's actually SLN innervation, not RLN innervation. And so there's, I think, reasons from an airway closure standpoint why it's important to make this differentiation. I think there's importance from a sensory standpoint why we'd make it. Plus, just the actual term for aspiration is below the vocal folds, not below the top part of the vocal folds. Okay, there's my spiel. Okay, the next boundary would be our subglottis. Actually, no, I want to go back here because these are good images. When we get to rating vocal fold residue, which we'll practice, what we're doing is we're thinking about anything in the blue shaded region. And then, you know how with the oral pharynx, we're like, okay, anything in the oral pharynx, put in the vallecula. Hypopharynx, anything in the hypopharynx, put in the piriforms. We're doing now the same thing with the vocal folds. We didn't do it for epiglottis and vestibule, but we're doing it for the vocal folds now. So anything in the blue shaded region, put on top of the membranous part, superior part of the vocal folds. That's what we're doing. So look at anything in the blue, put it right on top, like image number 4. And now we're saying how covered is this blue shaded region with any vocal fold residue? How covered is the superior part of the membranous portion of the vocal folds with any vocal fold residue? And so this could be a rating of, if we said 100%, all of this is covered. We could say something like 200%, which should mean like all of this is covered. Plus we have all of that still that's could cover the superior part as well. So this could be a rating of 0% all the way up to maybe something like 200% technically. We'll get into that in a little bit more detail, but any questions about vocal fold boundary or a little bit about what I just said right now? Okay. Next boundary would be the subglottis. So here, this is now our boundary for aspiration, right? Would be the subglottis. So anything in this blue region would be the subglottis. It's just anything below the glottis, anything below the vocal folds is the subglottis, right below. Contained within the subglottis is the subglottic shelf, which is the space between the lowest part of the vocal folds, but not including the actual lowest part, but like right immediately below that, up to the point of that first ridge that we're seeing, that we should be seeing, the cricoid cartilage, not including the cricoid cartilage, but like immediately up to that point. So that's the subglottic shelf. That first ridge is typically the cricoid cartilage, that first kind of prominent ring that we see typically. Of course, people's anatomy are different. Sometimes they're super edematous, and sometimes they've got really weird like scar tissue and other stuff, and it might not be that, but typically that's what we're thinking about. And then below that would be the trachea. So I'm separating these on purpose because the idea is that First, just know your anatomy, but then also when we start to make our subglottic residue ratings, we're looking for anything in the blue shaded region, just like with oropharynx, hypopharynx, and vocal folds. And then we put all of that into the subglottic shelf. And we say, how covered is the subglottic shelf with all of this residue? Which means someone could have more than 100%, right? If all of the blue was actually covered with residue, well, that's more than just this triangle. It's like 2 of those triangles or a little less. So it might be like a rating of 190%, right? So that's kind of, that's what we're doing with subglottis as well. This would be another vantage point of the anatomic boundary for the subglottis. So you're essentially thinking about where's the lowest part of the vocal fold, where's the lowest part of the vocal fold, extend those lines so they connect, or what looks like it's between the vocal folds. So something around like right here. And then anything below that point would be the subglottis, not including that border, but below that border. And so actually, what we're doing is we're looking at an image like this and thinking about it like this. And then with our boundaries, what we're doing is with VASES is anything that's on the boundary is the thing that's actually higher up. So if we're looking at this black line, the black line would technically be, it's the border, but if we had to pick, if like residue was on that line, we would say it's oropharynx. If residue was on this line, that's technically the border, but if residue is on that line, we'd say it's the epiglottis. If residue is on this line, we'd say it's vestibule. If residue is on this line, we'd say it's vocal folds, right? Even though there's the boundary separating those 2 structures, if it's on it, but not confidently crossing that, then we're saying it's the thing that's higher up. If it's on this line, we're saying it's hypopharynx and not vestibule. And then the idea is that this is how this lines up with video fluoroscopy, right? And so this is what I was saying with the head and neck cancer staging. It's essentially the level of the hyoid bone and above. Some authorities will say the top of the hyoid bone. Some aren't that specific. Some will say top of the hyoid bone, but then they'll actually do the top of the epiglottis in like a picture. So it's a little inconsistent. And I think as speech pathologists, we tend to get a little bit more granular with some of our stuff. And so this is the intent here, right? Because this is where the epiglottic folds probably merge in the epiglottis right here. This is where we start to get the petiole. So this is probably that junction. And so this is what we're trying to essentially capture as the oropharynx. Our camera on FEES is probably down here and then looking down on here. There's actually some part of the oropharynx that we don't see on FEES typically, right? Even if we're higher up looking down, then we're still like missing this part of the oropharynx. So there's regions of the oropharynx we're not missing, but are still technically captured by our definition. So those are the anatomic boundaries. Questions about any of these anatomic boundaries before we review our temporal boundaries? Questions on how you would draw the boundaries, questions on the rationale for the boundaries. Okay. All right, so we've talked about the where of VASES. Now we'll move on, and we actually have kind of talked about the how, but now we'll move on to the when of VASES, which is our temporal boundaries or temporal phases. So we have 4 temporal phases, which we can think of as a continuous cycle from the very start of the trial to the very end of the trial until the next trial. So we can separate it as the before the swallow phase, during the swallow phase, after the swallow phase, and then between both trials. So a little bit more kind of larger picture, we've got like swallow between both trials. Each phase has an onset and an offset, right? So the offset of one phase right here is the onset of the following phase. So let's talk about the onset and offset of each of these phases. Before the swallow phase. This is being defined as when food and drinks first enter the oral cavity. That's what we're trying to capture with the onset of the before the swallow phase. With fees, our current scopes don't typically retroflex 180 degrees, and so we don't typically see the oral cavity, so we don't typically know when food and liquid enter the oral cavity. And so this is inferred, which I don't like, but it's inferred. And so some of this, how you actually do your fees can start to influence the accuracy and consistency and reliability of your phases. So when I do fees, I'll typically do a verbal announcement of like the start of the trial, right? And so sometimes it's not exactly when food and liquid is entering the oral cavity. Sometimes it's when the utensil or the bolus is touching the lips. Sometimes it's just as a person's bringing it to their mouth. And so these are things that I'm doing that tell me this is now the onset of the before the swallow phase, right? And so I encourage you to do something similar. You might come up with another trick. You might like wiggle your camera in a certain way or like some sort of cue to say like, this is the onset of the before the swallow phase. This goes until the onset of the during the swallow phase, which is the offset of the before the swallow phase. So the onset of the during the swallow phase is characterized as the onset of uninterrupted motion of the postcricoid region lifting up and leading to the swallow, right? Uninterrupted meaning it doesn't like lift up and then stop, pause for a second, and then start to go again, or doesn't like go up and then go back down or something like that. Like it goes up and it leads into the swallow. Oftentimes that's endoscopic whiteout. But if someone has very little pharyngeal constriction, there might not be endoscopic whiteout. So that's kind of the main thing that you're looking at. In our original document, we also talk about like pharyngeal contraction leading to the swallow. That's good. I think people can start to kind of like, there's a lot of pharyngeal wall movement that can actually start to happen. And so I think it can kind of throw you off. The main thing that we're actually thinking about is essentially laryngeal elevation, right? This is postcricoid. These structures are attached to the cricoid, which is the larynx. And so we're really thinking about laryngeal elevation. I'll say that when we think about video fluoroscopy, the start of the swallow is typically defined as that first brisk uninterrupted motion of the hyoid leading to the swallow. And so many people assume that the hyoid movement is the onset of the swallow. That's good. That's how it's often taught, but that's not actually how you define the start of the swallow. We define it neurologically. And so it has to do with neural function of different muscles, right? One of the first muscles to often fire is the mylohyoid muscle, which is very much attached to the hyoid. And so we get hyoid movement because of contraction of the mylohyoid muscle. But actually, one of the precursors to that often happens actually before that is velar contraction, contraction of the velum, if it isn't already contracted for voluntary reasons. And so, so some other methodologies for video fluoroscopy will actually use velar elevation as the start of the swallow. The more popular one that we're probably aware of, MBS-IMP, uses the hyoid. And so a lot of people start to think about the hyoid. But the reason I'm bringing this up is that there's actually differing definitions of how do we define clinically the onset of the swallow. And it actually has to do with neurologic function and firing of muscles and neurons, right? Which we don't see clinically. So then we took clinical measures, and common one is the hyoid. I'm bringing all of that up because something I will sometimes use is blurring of the camera. Like if we have a quick little like frame of blurring, I think that's probably associated with velar elevation. And so I'm bringing this up because we might have blurring of the camera, and then it might actually look like the larynx is going down, but it's because the velum presumably is actually elevating and hitting the camera up. And so if that blurring happens and then it's still preceded by uninterrupted motion of the postcricoid region, then sometimes I'll use that blurring if the postcricoid is immediately following suit, because it's a very clear point in time for us to judge it. If you have a very high definition camera, you might not get that. And if the person's like guarding a lot, their velum might already be contracted and somewhat elevated, so you might not get that either. So you're really thinking about post-cricoid elevation, but sometimes that might be immediately preceded by a brisk blurring frame of the camera, in which case you could use that. So this is the onset of the during the swallow phase. If we were to judge things like bolus location at swallow onset, we would identify that singular frame or that maybe that blur. And we would pause the video clip and we say, where do we see bolus? Do we see it in the oropharynx? Yeah, okay, we see it there. Do we see it in the hypopharynx? Yeah, we see it there. Do we see it on the epiglottis? Yeah, we see it on the epiglottis. Do we see it in the vestibule? Nope. Vocal fold? Nope. Subglottis? Nope. All right, so here, bolus location at swallow onset includes oropharynx, hypopharynx, and epiglottis. We're not just taking the worst, we just say, where do we see it and indicate all the structures. That's how I would do it. Then if we extend and we kind of continue with the swallow, then we have to go to the offset of the after the swallow phase. So if someone just did one swallow, then the offset of the after the swallow phase would be when that post-cricoid region first returns to its lowest resting position after the swallow. Okay. So when it first returns to its lowest resting position, there might still be continued pharyngeal kind of lateralization of the wall, like relaxation of the wall. There might be continued movement, but when does that post-cricoid, that UES inlet slit, when does that first return to its lowest resting position, right? That's the frame that we're looking for. If someone does multiple swallows, that's all considered in the during the swallow phase. So someone could have 3 or 4 swallows that are contained within this time frame, in which case it would start at that onset of the first swallow. And then we think about when the post-cricoid returns to its lowest resting position after that last swallow, assuming there wasn't vocalization or more than 5 seconds of rest or camera advancement, which gets us to the next temporal phase. If you're feeling like this is a lot right now, it is. This is the hardest part of VASES. Okay, so just stick with it. I'm recording it, review it, and we'll practice more too. So to know this time point, the offset of the during the swallow phase, you kind of have to work your way backwards by thinking about the after the swallow phase first. So I'm going to go there and then we can work our way backwards too. So the after the swallow phase begins at this time point that we just talked about, and it goes up until the first of any of these 3 events. They swallow, and there's 5 seconds of rest. The moment we get to that 5 seconds of rest, we're at the offset of the after the swallow phase. Great, they swallowed, they're breathing, 5 seconds goes by, that's now the offset of the after the swallow phase. They might vocalize. So maybe they swallow, they breathe for 2 seconds, and then they start to talk because they're really talkative. Or they go, or vocalization could be like a cough or throat clear as well, right? Something with the vocal folds, right? Or maybe they swallow, they rest for a couple of seconds. We're really eager to see what's going on, so we advance our scope. The moment we start to advance the scope, that's the offset after the swallow phase as well. Okay. So if someone swallows and then they rest for a couple of seconds, but then they swallow again, that's not any of these events. So now we're still in the during the swallow phase, and we kind of reset our timer for 5 seconds. When it returns to its lowest resting position, reset for 5 seconds. So maybe we have onset of this. They swallow once. They finish the swallow. They breathe for 2 seconds. They swallow again. They breathe for 2 seconds. They swallow again. They breathe for 2 seconds. They swallow again. They breathe for 2 seconds. Those 4 or 5 or however many said swallows are all now in the during the swallow phase. But that last swallow, the 4th one, it returns to its lowest resting position. Now they've breathed for 5 seconds. And now that 5 seconds brought us here to this time point. That's the after the swallow phase. Or now they did those 4 seconds and then we're like, okay, just say E. And then they said E, they vocalized, we advanced our scope. Now that's the offset of the after the swallow phase. If it was just one swallow, super easy. They swallow, It returns to a slow resting position. Ideally, they wait for 5 seconds. We hopefully told them at the beginning of the exam, try to avoid talking. They breathe for 5 seconds, and that's it. Now that's our after the swallow phase. I will say this, I think, brings up a good point. Typically, when I introduce fees and I'm describing it to the patient, I'll talk about the risks associated with it. I mean, I put them at ease and hopefully they feel pretty comfortable. But I'll say things like, it might feel a little weird or uncomfortable at first, typically get used to it after around 15 seconds or so. I'll typically say your mouth might be a little, colored from the foods and liquids that we're going to give you, and you might have colored bowel movements for a couple of days afterwards because of the colors that we're going to give you. It's got food dye in it, so don't be concerned about that. I'll then also say, throughout the exam, we want you to avoid talking as best as able unless you need to express discomfort or pain. Because we're looking at your breathing and your swallowing, and we don't want to interrupt it with your voice. I'll also say, we'll probably have you say E after almost every swallow. Don't start to do it on your own. Don't start to guess when I'm gonna ask you to do it. Wait for me to tell you. Again, because we just want to see you kind of rest after every swallow. And so I'll typically lead into that for every fees. I am in an outpatient setting. I'm not inpatient. And so it's a little bit easier, but I do that in part because of this, because of our VASES kind of guides for interpretation. So I want to get to that 5-second mark. I'll also say that we needed to come up with a temporal thing. And so 5 seconds is a little arbitrary. We scanned a lot of clips and thought that seemed like it was a good marker, but it was kind of arbitrary in the front end of things. And so maybe over time, as research continues to develop and evolve, we'll find that maybe this will change to 4 seconds or 8 seconds or something. So we just needed a starting place. And so that's the idea. Our last temporal phase is the between bolus trial phase. And so this begins at that 5-second mark. So this is really kind of 4.9999 seconds. 5 seconds begins, and now we're in the between bolus trial phase, okay? Or they just vocalized immediately, kind of like at that vocalization or afterwards, or immediately after scope advancement. And then this goes until the onset of the next swallow. So this could be 30 seconds. We give them another trial. It could be 5 minutes. All of this is between bolus trials. This is a much less kind of rigid time point, right? So our residue ratings, we have 1 residue rating for each anatomic structure, so 6 residue ratings, are intended to capture this singular time point, right? We have all of this time with VASES, and this is what we're intending to try to capture at this time point, which may or may not reflect how bad or good you think their swallow actually is. The point is that we're giving a residue rating or being clear about when this residue rating was given. It was given at this time point. That said, before they start to say E and open up their vestibule, we might not be getting great views of everything. And so we can use the between bolus trials phase to inform our residue ratings, right? Most of the time, that is what's happening. So most of the time you're advancing your scope, you're in this time zone essentially, and you're making your residue ratings. And assuming there's not like bolus that's moving all over the place in this time frame, that's fine, right? If there is, then you're just doing your best to try to figure out what was residue like at this time point to the best of your ability. Okay, the last couple things for these time points is the PAS. So essentially we have, and this might be a little different than how we first published it, there's essentially 2 different PAS scores that you'll give for every swallow, and then you report the maximum clinically. So the first PAS score is what we call PAS swallow. So it's before, during, after the swallow phase. So essentially, we take the deepest point of airway invasion across all 3 of these time points. And we use that for the level of penetration aspiration. And then we use this cutoff as the cutoff for silent versus non-silent aspiration. All right, so remember that the PAS is an 8-point ordinal scale used to describe the depth of and reaction to airway invasion. where PAS of 1 indicates no penetration aspiration. PAS 2 to 3 indicates that something entered the vestibule but didn't contact the vocal folds. 2, it was ejected. 3, it wasn't. There's something remaining. 4 to 5 means that something entered the vestibule and it did contact the vocal folds, with 4 being it was ejected off the vocal folds and out of the vestibule, not just 1. 5 would indicate that there's something stuck somewhere. It's on the vocal folds and or it's in the vestibule. And then 6 to 8 would be aspiration, right? And then 8 would be, 6 is it's ejected completely out of the subglottis, but there can still be stuff on the vocal folds or vestibule. 7 would be that there's something stuck somewhere in the subglottis still. And then 8 would be that there was no attempt to eject. They didn't cough or throat clear. And so to define that they didn't cough or throat clear in a timely manner, this is the time point that we're using. So if they aspirate before the swallow, during the swallow, or after the swallow, but then they don't cough at this time point, then it's silent aspiration. If they do aspirate on any of these temporal phases, but they cough before this time point, then it's non-silent aspiration. It's a PS of 6 or 7. You can use these temporal phases to also indicate when did airway invasion first occur. So you might say it occurred during the swallow, and that's great. And maybe there was continued airway invasion after the swallow, but it first occurred during the swallow, right? Yes. One of the other inferences we make with PAS and with VASES, which trying to limit the number of inferences, is when the airway invasion occurred. So oftentimes we won't see anything before the swallow. We're not seeing active penetration or aspiration in the after the swallow phase, but before the swallow, they didn't have anything in the vestibule, and now after the swallow, they do, right? And so something happened during like the whiteout period. So that's the one time we make an inference that it happened in the during the swallow phase. So we're trying to advance our scope here or here. We're seeing stuff in the vestibule, but we didn't see anything before and nothing was changing with bolus after. So we make the assumption that it occurred during the swallow. All right, so there's the boundary for silent versus non-silent aspiration. And then we have the PAS between. So PAS swallow was our first PAS. PAS between is our second PAS. And so here is a second PAS. And so we are indicating if there's a change in bolus flow. So if bolus moved from one region to another region, that would generate a new PAS score. Or if they previously had aspiration here, they didn't cough, but then they did cough here, then we would give it a new PAS score indicating that they tried to eject. But we don't repeat otherwise. So if someone had, like, let's say a PS of 5, they had residue that was on the vocal folds, it was uncleared, and then they still didn't clear it here, we're not going to give them another PS of 5 because that would suggest that they had another penetration event, but they didn't. They just didn't clear it to begin with, right? If they aspirated here and they attempted to eject, but they couldn't eject it, and then they attempted to eject here, there wasn't really, they had already did that ejection, and so it doesn't count. If they had an aspiration here and it was silent, but then they attempted to eject here, then we would say, okay, now it's, there was an attempt to eject being made. If this was a PS of 5, there was residue on the vocal folds, but then that residue then spilled in the airway, or the subglottis, then we would say now there's aspiration because now there was a change in bolus flow. It moved from one region to another region. And if that did happen, they've got until this time point to cough or throat clear. Otherwise, it would be silent aspiration. So again, it's a little less standardized now because for some person, this could be a 30-second window. For another person, this could be a 2-minute window, but this is it. Okay, questions about temporal boundaries? This is the hardest thing. Yeah.
The role of scope advancement.
Mm-hmm.
Because you're attempting to rate right at that point between after the swallow
Yeah.
and between bolus trials. But if if scope advancement's happening at that after the swallow mark ending that phase,
Yeah.
then are you rating post-scope advancement? Are you rating during?
So the question is like kind of the role of scope advancement, how that influences our temporal boundaries and how that influences ultimately our residue ratings. And so once we start to advance the scope, we're now between bolus trials, right? just so you understand, the reason for that is that the reason we made that between bolus trials was because we didn't want to have scope advancement influence our interpretation of someone's sensory response. So we didn't want to have them cough or throat clear and be like, wait, was that because we're now like doing something with our scope, or was it because of them, right? And so that's why we did that. The moment when we start to advance the scope, now we're in the between bolus trials phase. And so this is what I was mentioning earlier, is that you will very likely, like 98% of the time, use images from between bolus trials to inform your rating of what residue was like there. And that's okay to do, assuming there's not like bolus is not just like flowing from one region to another region constantly. And even if it is, you still might have better images here, and then you're making a little bit of a guess of what was it like here to the best of my ability. That's what you're trying to do. So this starts to kind of show you, again, how you interpret your fees, even if it's not VASES, but especially if it's VASES, it's going to start to influence how you actually do your fees. So hopefully you start to be like, okay, yeah, I'm going to give them a little bit more rest. I'm going to hold off on having them say E for a few seconds. I'm going to hold off on my scope advancement for a few seconds, because we don't want to start to artificially change our interpretation based off of our habits. Like we want to like have them be standardized with themselves. But yeah, so we wait 5 seconds, ideally, we advance the scope. We're now in the between bolus trial phase, and we use those images to inform what we think of is happening right here.
Can I ask you a quick question, James?
Yeah.
So when you are telling the patient to actually, you are at some point telling them to say E, is that when you're saying you're advancing the scope? At that point, you wait the 5 seconds, no talking, then you say E, advance the scope to look.
Exactly. Yeah. So I'll, you know, it also depends on like the complexity of the patient, can they follow directions, all that stuff. But yeah, so I'll typically wait 5 seconds. Sometimes it's not the full 5 seconds, right? But I'm waiting, and I've asked them, and I kind of remind them throughout, especially if they need the reminders, to avoid talking to the best of their ability and just relax afterwards. I'll be like, great, swallow, good, and just relax. All right, chin up and give us an E, and then I'll advance then. Sometimes it's a mild chin up because I'm just trying to get that like neutral, bigger molecular space. I'm trying to make my life easier. If the patient is complex and whatever, and that's going to take forever and get them confused, and I don't do that. But yeah, so I'll wait, and then I'll have them say E, and I advance the scope a little bit. And sometimes I don't even advance the scope that much anymore. Like if we're using, especially if this is being recorded and being viewed elsewhere, in the United States, you can use white dye. So if we're using good colorants that are easy to see, there's sometimes not a huge necessity to advance the scope if we're having them say E, because typically that opens up the vestibule. When not, then we can see subglottically. But if you need to advance the scope, you can totally do that as well. But yeah, so typically wait, breathe, say E, and then advance, plus or minus advance.
Can I ask you one more quick question?
Yeah.
Can you just reflect on, you said something in judging PAS 4.
Yeah.
Did you say it has to be out of the vestibule?
Yeah, I didn't realize that. And then I realized that. So that's, yeah, 4 is, so 2, right? That's into the vestibule, and then it's now out of the vestibule. 3 is, there's some amount remaining. It could be like a line. It could be more than a line. 4 and 5 is at the vocal folds. 4 means it's off the vocal folds and out of the vestibule.
So you're considering the definition of the penetration aspiration scale, right? Uses that kind of broad airway, out of the airway, I think. What does it say? Right. Yeah. So you're saying instead of out of the airway, further defining that, meaning out of the vestibule.
Exactly. And then when I've spoken to like developers of the PAS, that's yeah, they said it's both. It's out, completely out.
Okay.
So I don't think a lot of people actually realize that. But yeah, there should be nothing left. It's like they had no airway invasion to begin with.
That definitely should be, that's great to bring transparency to that.
Yeah.
Especially with clarifying that intent.
Yeah, well, and then also the 6, I mean, 6 I feel like is less confusing, but 6 is when you start to realize that, then you might start to be confused about 6 when you learn about 4, but 6 is just out of the subglottis, but there can be stuff remaining on the vocal folds and subglottis. The PAS, if you read the original article, was actually used to be a 9-point scale, where like their version of 6 essentially was completely out of the subglottis, vestibule, and vocal folds, but that never happened in like their 1,000 swallows that they analyzed. So then they made it just out of the subglottis, but it can be on the vocal folds or subglottis or vestibule. So, okay. But
I'm
yeah.
sorry, can I ask?
Yeah,
So
no,
six, so
please.
6 on the PAS is defined as material enters the airway, passes below the vocal folds, and is ejected into the larynx or out
Or out.
of the airway.
Out of it, yeah. So it can be it's ejected, and there can be something left behind on the vocal folds or vestibule, or there can be nothing left behind. But like
Okay,
it just means that there's nothing left in the subglottis afterwards.
got it.
That's the thing. So there
Okay.
can be other stuff above, just not in the subglottis anymore, is the 6. And so 6 means, again, I feel like these are kind of harsh, and I don't know how practical they are with fees where we're like using dyes and staining mucosa, but 6 would be like literally nothing is left in the subglottis. So if they had like 90% covering of the subglottic shelf and then it went down to 1%, it's still a 7 because there's still something remaining, which seems harsh to me, but that's the scale. Which is why I think VASES is helpful, because now you're qualifying this a little bit more and you're saying, oh, it went from 90% to 1%. But still it's a 7. So 7, again, for transparency, would then be they coughed or throat clear, they tried to eject it, but then some amount was remaining in the subglottis. It was greater than 0% residue rating, essentially. So, and I've had questions before, like, well, what if, your residue rating is 0, but then they're like they have 0 aspiration, but then between both trials, they aspirate a lot. Your residue rating isn't capturing that. And yeah, the residue rating is not capturing that. But that's why we have the different PAS scores. So we kind of are trying to cast a wide net a little bit and still capture the impairment. And then you can still use residue ratings to further supplement PAS and further kind of enhance your report writing. But the standardized residue ratings are intended to capture what's present right there. And then we have PAS to kind of get across the entire thing. And then you can kind of further characterize things as needed. But I think that's something as people start to use VASES, they're like, but we're missing like all the stuff that's happening right here. Yes, but PAS is getting at that to some extent. And then you can still add additional language and still add additional comments. But this is the standardized rating. Other questions? I know we said we break at 10. No, we said 11. We said 11. Okay, great. Yeah, I just want to get through the rules again, and then I guess that'll leave us with like 45 to 50 minutes for calibration. But I think this repetition was good. Okay. Okay, so we've talked about the where, we've talked about the what. No, we've talked about the where and we talked about the when. The when is the hardest thing. So just like spend the time, push pause as you need, reflect, think about it, talk about it, and just keep growing, because that's what we do as clinicians. Okay. All right, so now let's move on to the what of VASES. So the what of VASES refers to the actual outcome measures. You view a swallow trial, you hit pause, you pull out your rating form. What are the things you're actually rating, right? You rate the things that takes hopefully a minute or less. Bam, wham, you're done, move on to the next trial. What are the things you actually rate? When we, there are kind of 7 to maybe 8 outcome measures you could rate, plus or minus actually a couple of others. So the idea is that you're making ratings at the bolus trial level. I'll also say this, like you can use VASES just as a framework to be like, yeah, I just have a sense of anatomic and temporal boundaries. And like that, I think is already super helpful. But you can also use it to then come up with ratings that you're actually reporting as well. So that's where this comes in. But I think at the very least, just like real-time interpretation using these anatomic and temporal boundaries kind of gets us all on the same page. And I think that's very valuable. But if you were going to do ratings, whereas things like MBS-IMP is kind of at the protocol level, worst overall, this is trial level. You view a video clip, push pause, make your ratings. And there are a collection of different measures that we can look at. And then from there, across a single trial or all the trials in a protocol or some of the trials in a protocol, you can report all of the ratings. You can, I would at least report all of them, but then you can also do like, oh, what's the average rating? What's the range? What's this? What's that? So our outcome measures include estimating the amount of residue that we see, covering or filling each of these different anatomic structures. So we can think about oral pharyngeal residue and hypopharyngeal residue. And then we also have epiglottic, vestibule, vocal folds, and subglottis. So we have 6 different residue ratings. We're going to get into how to do that in a few slides. This is just the what right now. We also have the penetration aspiration scale. We've already kind of gone through this now. But essentially, here's table 2 from that original article, the final version, because I told you the first version was actually a 9-point scale in that same article, table 1, I think. And this is the final version. This is the one that we all know and love. I'm not a huge fan of it for fees, but do it because everyone else does, and it's good. It's good. It's good. I just have some issues with it. But here we go. So PIS 8, or PS is an 8-point scale meant to describe the depth of and reaction to air invasion. A PIS of 1 would indicate that there was no penetration aspiration. That's great. Good for them. A PIS 2 to 3 would indicate that there was entry of material into the laryngeal vestibule. Here they say airway, but for the purposes of VASES, we're trying to be more transparent and we're saying the laryngeal vestibule. And now you know what the boundary is for the vestibule per VASES. Within each of these levels, we have ejected versus not, or the response to air invasion. So 2 would indicate that it was ejected out of the vestibule with nothing left behind afterwards. A 3 would be that there's still something there. Maybe most of it was ejected, maybe none of it was ejected, but there's still there's still something there, right? That would be residue. 4 to 5 is our next depth of airway invasion, which would be now the vocal folds, right? So now something has contacted the vocal folds at some point. A PS of 5 would indicate that there's still something there between bolus trials or whenever, right? And so it's either still on the vocal folds and or within the vestibule. So it can be one or both. It could be vocal folds, vestibule, or both. Both. A 4 would indicate that there's nothing left behind on the vocal folds or in the vestibule. It's as if nothing ever happened to begin with, right? That would be the PS of 4. PS 6 to 8 would be aspiration. So now 6 would indicate that there was aspiration, so something went into the subglottis, and then an attempt to eject was made and was successful at clearing everything from the subglottis. Things could still be on the vocal folds, things could still be in the vestibule, there might not be anything, but regardless is there's nothing in the subglottis. That's a 6. 7 would be there was an attempt to eject made with a cough or throat clear, and something is left behind in the subglottis, right? Maybe nothing was ejected, maybe almost all that was ejected, but if there's anything left behind in the subglottis, it's a PS of 7. And a PS of 8 would indicate that there was no cough or throat clear. There was no attempt to eject being made. Or maybe a vocalization. That one's kind of hard to judge, but maybe we might have something like that with some of our neuro patients, right? There was some sort of attempt to eject being made for 6 or 7. 8, nothing. They were just on vacation, enjoying life. Okay? So that would be our PS of 8. And then again, we're using that attempt to eject being made. We're thinking about the boundary cutoff, so after the swallow or between bolus trials, okay? So we use our anatomic and temporal boundaries, which we just talked about with VASES, and we are applying those to the penetration aspiration scale. And as I don't know if I mentioned this time or not, some people might take issue to that. Some people might say, well, you know, they didn't go into this detail with anatomy, now you're imposing that. Or, oh, they didn't go into detail about the temporal boundary cutoffs for ejection versus not. And that's fine. And I think that's a valid point. And so, great, but the alternative is just not being standardized or transparent about how we're using PAS. And I think this is the lesser of the two evils, is imposing this transparency per VASES. And then if you want to make adjustments in the future, you can, but to me, this makes a lot more sense. Okay. So we have our 6 residue ratings. We have our PAS swallow, PAS between, report the max. And then we have, if you wanted, you could also talk about bolus location at swallow onset. It adds some clinical time and burden to you. I think it's important for training and for learning. Not 100% sure of the clinical utility. We know that there's a lot of healthy variability with bolus location at swallow onset or pharyngeal swallow initiation. In healthy adults, it doesn't seem to be a big deal. In patient population, there does seem to be some correlation with bolus location at swallow onset and functional swallowing outcomes. So something to keep in mind. I'm just not sure how strong that correlation is, but nonetheless, this is in the norms study. You can see the normative distribution of these ratings. But essentially what you do with bolus location at swallow onset would be pause that frame of the onset during the swallow phase, and where do you see bolus? And for the norms of study that we did, we rated everywhere that we saw. We didn't just do the lowest. And so you can see the frequency that bolus was seen on each of these structures. This measure really should only be made if you're having visibility of the pharynx and larynx at the onset of during the swallow phase. There are many times, maybe not many, we didn't see it many in the healthy adults, but that you might have whiteout and you might not see the onset during the swallow phase because maybe their velum is already elevated and hitting your camera, or maybe there was bolus that was like already in the pharynx and covering the camera before we had that post-cricoid elevation, in which case you just leave this outcome measure blank because you're not seeing the onset of during the swallow phase. So those are the what? Our residue ratings, our PAS ratings, maybe bolus location at swallow onset. The other thing I also typically will rate, and it's not so much a VASES thing, will be the number of swallows that were completed for every trial, because I think that informs how we contextualize our residue ratings. And then I also record sip size and bite size, because I think that also informs our residue ratings and our PAS scores. So those would be additional measures you could think about incorporating into your rating form. Would be number of swallows and then bite size and sip size. All right, question about the what? Or outcome measures of VASES. With these measures, with the what's, there might be ways, we're currently studying it and hopefully publishing on it, that you could derive other things like digest scores, which give us overall ratings of overall impairments in swallowing safety and efficiency, right? So that's also possible. You might include other things. You might include things like secretion scale scores, and you might kind of use how you're looking at piriforms for secretions to inform these scales as well. So there's definitely other scales you can be using, but these are the what of VASES specifically. All right, so now we have the how of VASES. So this is the actual rating methodology. So the where were our anatomic boundaries, the when were our temporal boundaries, the what is what's on a rating form, what are we going to rate? And now, how do we go about doing that? Like, what are you actually doing to come up with this? So, so in this section, we're going to talk about the methodology of coming up with these ratings. After this section, I don't know how long this will take. Hopefully not too long. We'll take a quick little break and then we'll do some calibration practice. So just hang with me a little bit longer. So let's talk about how we do our residue ratings. So these are made using percentage-based estimations, right? We're looking at a video clip and we're guessing essentially how filled is something, how covered is something. Like that's what we're doing. When we first published this, we used a visual analog scale. So that's a line. It's a line, you place a marker on it, and then you do some measurements from there. But you can also do verbal numerical ratings, meaning you can just think of a number and just report the number, which is easier. Understand that there's some cognitive biases and traps that you start to probably fall into with verbal numerical ratings and you do with visual analog scales, where maybe you start to find yourself getting this habit of like putting in ratings of increments of 5 or increments of 10 or something like that. And so you want to be careful that like you're not falling into these traps. So just kind of be aware of that. So residue ratings are intended to capture the amount of residue observed at the offset of the after the swallow phase. That's what we're trying to do with residue. What was it like at that point in time? We already mentioned this, but you'll probably get better visualization and more comprehensive visualization of other structures between bolus trials as you're kind of moving around the scope or as you're asking them to just say E and things are changing, right? That's vocalization. That would now be between bolus trials. And so assuming there wasn't any change in bolus moving from one location to another or other stuff, you can use those images. If there is a change in bolus flow or location, you can still use those images. You might just have to do a little bit more guesswork about what was it like right before the bolus started moving. You're not just picking a single video clip either. So now I'm on this last sentence, right? You're likely kind of synthesizing from multiple different time points and kind of putting that together to come up with your residue rating, especially for structures that you're not seeing all at once, like the epiglottis, where sometimes you see the top of it, the other times you see the bottom of it, right? So that's okay to do. You don't have to find the perfect picture. So with that construct in mind, when we think about oropharyngeal residue ratings, we're asking ourselves the question, how filled is the vallecula with oropharyngeal residue? That's the question that goes into my head. I'm looking at how filled is the vallecula with oropharyngeal residue? So to do this, we look for any residue that's anywhere within that blue shaded oropharynx that we showed you. Put it all into the vallecula, make the vallecula its largest space, and then within reason, and then ask yourself, how filled is that? We're estimating the filling of that three-dimensional space, and we're not thinking about coding of structures, right? We're just thinking about how filled is that three-dimensional space. And as we mentioned earlier, we're trying to standardize that housing space size to its like neutral largest, right? So maybe it's a slight chin up posture, just kind of opening things up a little bit within reason. And that's kind of the housing space size that we're thinking about for them. So how filled is that vallecular space when it's that size? How filled is that with oropharyngeal residue? The ratings typically go from 0 to 100%, but theoretically you could have more than 100% for this. Probably not for liquids, because if it's liquids, it's probably spilling down into other structures. But if it's food, the vallecula might be filled 100%, and there might be still a mound of stuff on top of it. So then you imagine how big is that mound if you were to kind of put it, if you were to like take out all this and then put it into the empty vallecula, and then you're using that percentage. So it's possible to have a rating of more than 100%. For both the oropharynx and the hypopharynx, we're thinking about filling of that three-dimensional space. We're not thinking about coating of mucosa. For other structures, we are, but for these structures, it's not about coating, it's about filling. Okay, so keep that in mind. So if all of the mucosa was completely coated and covered, it would still be a rating of like 1 to 3% because it's not filling that three-dimensional space. It's just the mucosa has been stained. That's it. But there's still something there theoretically, but it's not filling that space. So most liquid will already be in these pockets because it's falling into gravity, right? So we don't have to do much imagination of like putting stuff in the vallecula. But for foods like purees and solids and stuff, there might be stuff stuck on the base of tongue or stuff stuck on the pharyngeal wall, and then you push it down or in or whatever into the vallecula, right? So here there's nothing in the oropharynx. Here we're seeing some white stuff. Here, this is base of tongue. It's not in the vallecula, so we'd put it down there, right? This is, some of this is the oral pharynx, put this in here, but it's just staining of mucosa. So 1%, don't even give it much mind. Here we have a lot more coating, right? It's possible there's a little bit of filling that's starting to happen. When I first saw this image, I thought it was all just two-dimensional coating. So I gave it a reading of like 3%. But if we thought that was three-dimensional pooling, it might be a little bit higher. Our base of tongue is kind of cut off right now from the image, but we could probably open up the space a little bit more. And so if I thought this was a rating of, let's say, 5%, if we multiply 5 by 20, we get at 100%. So the question is, can I get 20 of these little guys in this whole molecular space before we're on the verge of overflowing? And I think, yeah, I think we could get 20 of them in there. So don't even think about the coating effect, just think about the little pool that you're looking at, and then keep yourself in check. If you said 10, then essentially what you're saying is, if this was a rating of 10%, you're saying, I can only get 10 of those in there before we're on the verge of overflowing over the rim of the epiglottis. And I think that's not the case. I think we can get more than 10 in there. Keeping in mind that we have to open up and kind of separate the tongue from the epiglottis a little bit more. This is something similar, right? So here we'll note that there is some like coating of stuff higher up on the base of the tongue where it's kind of meeting the uvula. There's a little bit of stuff there, but we could push this in here. This is liquid contained within the vallecula. And it looks like the housing space, you could kind of increase the space a little bit. Right side looks pretty good. Left side, it looks like it's maybe they're retracted a little bit. Maybe this is the biggest they can get. But if this was a normal person, I think that we could open it up a little bit. So then we're thinking, how filled is the vallecula with orofrontal residue? Again, if we thought 10%, then we're thinking we can only get 10 of these in there before we're on the verge of overflowing from here to there. I think we can get more than 10. Can we get 20 of them in there? Maybe we could get 20 of them in there. I could see myself giving it a rating of 5%. But I could also see if I was going kind of fast, I'm like, I don't know, it's somewhere between 5 and 10. Let me just call it, let me hedge my bets and call it 7%. There you go, 7%. I also like to do that approach because then I'm not sticking myself in increments of 5 and 10, which is a habit I think you can get into. Here, same concept, right? We can see that their pharynx is kind of constricted, so they're probably not the most kind of like a reasonable housing space size for the vallecula. How filled is the vallecula with orofrontal residue? And so I think when some people see this on the front end, they're like, oh, like 40% or something, because they're seeing that it looks like it's kind of up almost halfway. But recall that the vallecula is kind of like a pyramid, right? And so we're thinking about all the way over here, all the way over here, and also thinking we could actually create more space between the base of tongue and the epiglottis. And so I think we could probably get 4 to 5 of these in there before we're overflowing, maybe even a little bit more. So if I think we can only get 4 of those in there, that's a rating of 25%, right? Because 25 times 4 is 100. If I think we could get 5 of these in there, then that's a rating of 20%, right? Because 5 times 20 is 100. So I don't know, halfway in between, let's call it 22%. I could see 15 to 20% as well. I could see like, I don't know, 18%. But this is this, you know, if we go back to categorical variables, a rating of 25% starts to become severe in some scales. And then like a rating of 22% is still moderate in other scales. And so we're only talking about a couple of percent difference, but some scales might start to have this as a different category altogether. Which I think goes to show kind of the value of it being a continuous based metric. And here we're looking at, we have kind of coding throughout this. We have some of this stuff here, which can kind of push into here. There's probably stuff on the base of tongue that we're not seeing. We're seeing how filled is the vallecula with orofrontal residue. It looks like it's almost filled up to the rim. It looks like it's a decent vallecular housing space. So I don't think there's too much imagination of like creating more space. It does seem like it's not filled to the rim in this region. There's like a little kind of pocket or divot there. And so, yeah, I think we're at nearly 90%. I think we're at nearly 90%. I could see 95%. I could see a little less than 90. I don't see 80%, but a lot of times I present this, people say 80%. But maybe. So here we go. high 80s, low 90s. Questions about any of these images? All right, so hypopharynx will be a similar approach. So I'll go through this quicker. So how filled are the piriforms with hypopharyngeal residue? Look for anything in the hypopharynx. Think about putting it all in there. If it's liquid, it's probably already there. Standardize the housing space size. Normally it's by having them say E. Ratings, again, typically go from 0 to 100%, but you can have more, especially if it's foods. If it's liquids, it's probably spilling into the airway at this point, so probably not going to be a rating of 100% or more for liquids. Again, if we're thinking about filling of the piriforms and not covering of the mucosa, so if it's just coating, you're giving it a rating of like 1 to 3%. That's it. Okay. So nothing in the piriforms here, plus the piriforms are not in our largest housing space size. Here, piriforms look like a good space, but it's just staining of mucosa, so 1%. Don't even give it more cognitive mental effort than that. Here, I see coating in mucosa. I don't even care because my brain is now going immediately to these little pools. So I'm not even thinking about the coating of mucosa. And so you can, now estimate how filled are the piriforms, which extend from essentially now here, all the way up to here with the littoral channels, with hypopharyngeal residue. I would put this here. That's my way of doing it. And I think how filled is this one space? And then I would divide that in half because it's only half of the total piriform space. And so I think if we put this here, we could probably get around, I don't know, 5 of these in there, maybe a little bit more. So I think 5 of these in here, that would be a rating around 20%, right? And then I would divide that in half to get me at around 10%. But like I said, I think it's a little bit, we can get more of that in there. So I'm at a rating of less than 10%. And so, yeah, here I'm at like 6%. I think that sounds good. In other words, if I'm at a rating of 6%, I'm pretty much at 5%, which means I could get 20 of these in here before we're on the verge of overflowing. And I think we can. I think some people might be like, whoa, maybe not. But I think it's not unreasonable to be like there. If we said between 5 and 10, then we can get like 15 of those in there, right? So maybe that's 8%, right? That's the difference between 5 and 8% is for our ratings. Okay. Here, vocal folds are almost adducted. Essentially, it looks like the piriforms, though, even though they're not completely closed, like we have a glottic gap, but still the arytenoids are actually pretty much approximated. So the piriform space looks relatively large. I think if we moved all this on one side, essentially one piriform would be full completely. But that's only one of the two, and they look like they're equal in size. So it's a rating of around 50%. Here, ideally the vocal folds would be adducted more, right? But then we could put all this over here, and some of it would still be left behind. So probably at a rating around 50%, maybe a little bit lower if we got a better view of what the piriform space actually looked like. I'm gonna keep going, but just if you have questions, let me know as we go. I just want to get through this in the next 5 to 10 minutes. All right, so epiglottic residue. So those oral pharynx and hypopharynx is how filled is that space, okay? Epiglottis is different, and it could potentially change in the future. But right now, it's how covered is the epiglottis with residue? How much of this mucosal surface area is actually covered? So here, you're thinking about the entire surface area of the epiglottis. And it's bounded by this surface area, because now we're just talking about covering. So now this is bounded between 0 and 100% for our ratings. Here we are thinking about covering or coating of mucosa, right? So now we are shifting our mind a little bit. We didn't care about covering or coating with oropharynx, hypopharynx, but we do for the rest of these structures. As we do with all structures, not just the epiglottis, we think about both visualized and non-visualized surface area. And so that's kind of our mark for what 100% would be, right? But we only judge the residue that we see. So it's a little bit of a double standard because maybe you don't get the entire view of the epiglottis ever, but you still know that there's more epiglottis tissue there. And so you take that into account, but you don't guess that there's residue there. Even if the rest of the epiglottis is completely coated, we're not guessing what that last 20% of the epiglottis looks like. We never make inferences about residue with VASES. So this is just for kind of a little bit of calibration. So let's assume that we're seeing 3/4 of the epiglottis here, right? There's some epiglottic tissue kind of higher up, superior and anterior that we're not seeing. So let's say we're seeing most, but not all of the epiglottis, okay? So if that is the case, then in this top left image, we aren't seeing any residue, right? There's not these blue fictitious dots that I drew on them. The image on the right, we're seeing around 2% of the epiglottis is covered with epiglottic residue, right? This is taking into account visualized and non-visualized surface area. If we just looked at just what we're seeing, this is actually probably around 3.8%. I did this on a computer. So this is, I think, the numbers that I previously got. But we have to think about visualized and non-visualized surface area. And so this is a rating around 2%. If we look at the bottom right image, right, it looks like around 80% of what we're seeing is covered, but that's only 3/4 of the epiglottis. And so if that was actually the case, we actually have a covering around 60%, right? Because there's a lot of tissue that we're not seeing, and then some of this is not actually covered. So it looks like around 80% of this is covered, 20% of it's not. But again, what about the non-visualized surface area? Now we go to the image on the bottom left and we see the same spread. And this is what's very common to see with airway structures is it's not what I call this blanket effect. It's not completely coated. There's lots of tissue in between that's not coated. And so oftentimes if you just look at this and you hadn't seen that first, you would give this a rating around 80% or 60%, right? But I think what happens a lot of times is people are thinking about the spread, but not taking into account that all of this stuff is not actually in contact with residue. So the method that I do is I typically think about what is the spread if we don't have that blanket effect. It's not a blanket effect. What's the spread? Divide that number in half, and then give or take the residue rating a little bit based off of how much of a blanket versus how sparse the residue patterns are. So this is the same spread, and it's again spread around 80%, but around 60% of the entire epiglottis. And so if we did this method, if we did that 60% divided in half, it's around 30%, then we can give or take a little bit. You can see that actually lines up with what I measured on the computer, which is 35%, right? And actually that I would have probably come up with a number very similar to that because this is more blanket rather than less blanket. These aren't sparse fibers. It looks like it is more blue rather than less blue. And so that's how we'd go about doing it is think about what's the spread, divide it in half, and then give or take. So here we're not seeing any residue. Here we're seeing a couple little strands, so like 1%. Here we're seeing around half of the epiglottis, I would say. There's like the underside that we're not seeing. We're seeing spread around 90%, 80%, something like that. Because some of that's not, and then, but like a lot of this actually is kind of like almost a blanket effect. So I'm thinking it's more of a blanket rather than less of a blanket. So I'm actually not doing too much of a halving situation. So if I thought 80% of this was covered, but we're only seeing half of it, and we're at a rating of around 40%, but then I would probably take away some because there is some blanket effect, which brings me to around 35%. Here, I think we're seeing maybe 3/4 of the epiglottis. If I had to guess, we would have a better idea based off of our pre-swallow assessment where we're looking at all the anatomy, but almost all of it's completely coated. So if I'm thinking that we're seeing around 3/4 of the epiglottis, and I think almost all that it's actually coated, it's giving me a rating of around 3/4, right? 75%-ish. We do the same concept with the laryngeal vestibule. How covered is the laryngeal vestibule with residue? We think about the entire anatomic space of the vestibule and think about how much of that is in contact with residue. This, again, is bounded by 0 and 100%, right? This, again, we're thinking about covering, not filling. This again, we're thinking about visualized and non-visualized surface areas. And then we already talked about this approximate guideline that the left and right sides around 35 to 40% each, the middle is around 15 to 20% each, and then the intermediate space is like 0 to 5%. So we don't see anything in the vestibule here. Here, right, this would be, looks like a PAS of 5. There's something on the vocal folds and in the vestibule that's not been cleared, but it's only covering like 2% of the vestibule right now, and like 2% of the vocal folds or something, maybe 5% of vocal folds. Here, we could like move all of this blanket over here, and this is getting very full. This we can kind of consolidate and then move it over there. And now we're covering roughly like, if this is 40%, probably not all of it, probably around 30%. I previously gave it a rating of 25%. So I was somewhere between 20 and 30%. And I think I stick with that. Right now, I'm on the slightly higher end. I was at 30%. Right, and so this amount of penetration looks very different than this amount of penetration. So let's say this was only a PAS of 3. This PAS of 3 covering 2% is very different than this PAS of 3 covering 30%. We have a different idea of what that looks like. And so that's why I think these residue ratings are important. And now here it looks like a lot more of the surface area is covered, right? It looks like we could probably put this over here. It wouldn't cover it completely. Yeah, so a rating of around 65 to 70% again. And so what we don't want to do is think like, oh, 60% isn't near 100%, so that's not that severe. Like, we don't want to impose our own severity impressions on it. What we'll learn over time is what is severe, what is not severe. But severity is kind of an impression, a clinical bias, and we don't want to go there yet. We just want to be like, that's how much this is covering. And I will say, after having done this for a while, 60% is really severe. Like, that's a lot. And we can see that that's a lot, right? So don't get thrown off that the numbers don't feel like they're matching what you think the severity impression should be. All right, vocal fold, same concept, but we're adding the extra step of normalizing to the superior surface of the membranous part of the vocal fold. So just move anything in the vocal fold space on top of the vocal folds and do the same thing. Because it's normalized to the top, then we can have a rating here of more than 100%, because if all the top is covered and all the medial edge is covered, then it's going to be more than 100%. All right, so this is the same thing. Think about visualized and non-visualized surface area. I should say the reason why we are normalizing to the top of the vocal fold is because sometimes on fees, we don't get great images of the medial edges. We want to do something that we could consistently see. And so that's why we did that extra little mental effort. Here we have a really great view of the medial edge, right? But you might not always get that. Like in this example here, we don't really see the medial edge right now. And so that's why we went with that approach. So we would look for anything anywhere in the boundary, but essentially all of it is already here. Here it's kind of more ventricle space because of the shadow right there. So again, we're at around 2. I think we could get more than 20 of these on here before it's completely covered. Here, this image is only a little challenging to rate because it's hard to know like where exactly is the bottom of the vocal fold. Is it this or is it this? So that kind of throws things off a little bit. But if this was the superior part of the membranous part of the vocal fold, I think we could put all of this here. That would be now completely covered. So that's 50% covered. We have all this stuff that's in like the ventricles. We could push that over. That would cover most of this. That would be 75% with maybe a little bit left over. So like 80%. And apparently I gave it 85 beforehand. So I'm, again, pretty close. Now I'm a little under what I previously said, but there we go. And then the subglottic shelf is the same concept as vocal folds now. So it's thinking about anything in the subglottis, put it all in the subglottic shelf, and then rate how filled is this, how covered is the subglottic shelf with our residue ratings. So again, this could be more than 100%, right? If the subglottic shelf is completely coated and we still have a lot of tracheal residue or something, then it's how many of our subglottic shelves can we fit into our trachea that's being covered with residue, right? It could be 200, it could be 300%, right? That'd be a lot. So in this example, if these yellow rhombuses, I don't know my shapes anymore, but these yellow shapes, all right, we have one that's already in the subglottic shelf, one that's kind of on the cricoid cartilage and in the trachea. What we would do with our brain is we would pretend to move that up into the subglottic shelf. We would then try to conceptualize what is the subglottic shelf. Well, it's all the thing that we're seeing here, but then we know that's actually there's subglottic shelf underneath it that we're not seeing right now that's being covered by the vocal fold. So then that's our visualized and non-visualized surface area. And then we say, how covered is the subglottic shelf with all the stuff that was in the subglottis? And this example, I think it was, I don't have the number here, but I think it was around like 26.4% or 24.6% when I looked at it on a computer. So yeah, around 25%. And so this is a nice calibration too. Essentially, you could get around 4 of these in here before this is completely coded, right? And so I think the first time I saw this, I was like 4, but like, then you start to look at it and you're like, yeah, 4 actually. So bear that in mind. So here, there's nothing in the subglottis. Here, this would be a subglottic residue rating or an aspiration residue rating of around 3%. Right, thinking about visualized and non-visualized surface area. I like to kind of think about midline right there. So we could get around 20 of those in there. What we found in a recent study in people with neurologic diseases is that, and this seems to be true for healthy adults as well, a rating of 3% in the subglottis, people are not going to feel that. They're not going to cough or throat. Maybe they feel it, but they're not going to cough or throat clear to it. And so this, I would expect silent aspiration, right? And so using these subglottic residue ratings, we can then help to kind of characterize why someone may or may not be responding. Here, this is a rating of closer to 40%, right? So essentially we have this, which is not part of the subglottic shelf, that's the cricoid cartilage, we'd put that there. We have this that we're also seeing, we could put that there. If I drew this as midline, we also have some of this, I would think a lot of this half could be covered, but not all of it. So I'm like at 50, then I bring it down a little bit, so I'm at around 40%, which is where I'm at. So here, based off of our recent study on aspiration amount and airway protective responses, this we would expect people to cough or throat clear too. And if they're not, now I'm starting to think there's something up with their sensation, right? I think we had like around 20% is when we started to see lots of changes. Or maybe it was like 12%. I have to look at it again. All right, here, almost all of what we're seeing is completely coded. It looks like maybe some tissue isn't coded. I don't know. So you can see like sometimes maybe I'm thinking 100% because no, I do think it's coded. I just think I can kind of see through some of the mucosa. Some of it might be, I don't know if I can see through it or if it's just not covered. And so that's kind of getting me to like I don't know if this is a 90% thing, 100% thing. And then I think this is that ridge right there. So actually, this might be a rating of over 100% because this is now subglottic shelf plus cricoid cartilage, right? So as a general thinking about for these residue ratings, only rate the residue that we're seeing. Don't start to guess. Don't be like, I'm scared I'm going to miss something, so I'm just going to say something's there. Like, only rate what you objectively see. The challenge is being like, is that residue or is that not residue? So then you have to think about, you want to be more confident rather than less confident that it's residue. PAS we've gone through. So I'm just going to, PAS is vestibule for 2 or 3. Vocal folds for 4 and 5. Some extra notes that you can read, but we've already talked about them. 6 to 8 is aspiration. Again, some notes that you can think about. We talked about swallow and between. Clinically, you could probably report just the highest, but you might have both. You might list both. Okay, so those are extra things. Bolus location and swallow onset, we also talked about, so we don't have to review that again. And then the thing to end with are just some of the secondary rules I want to highlight, which is that just generally speaking, as a guiding principle for VASES, we want to be more confident rather than less confident about the thing that we're saying, like if there's an impairment there. So if we're looking at residue and we're like, is that residue? Is it just saliva? Is it a vein? Is it like their anatomy? If it could be reasonably judged as not residue, you go with that, like reasonably, right? That's kind of a vague term. You want to be more confident rather than less confident that the thing that you're seeing is residue. You also want to be more confident rather than less confident that the residue that you're seeing is what was just given, right? If it was like pre-existing and you're like, I don't know, that could have just been the stuff from beforehand, then you don't include it. You're judging the stuff that's new for every swallow of what was just given to. So yeah, if it can be reasonably judged as shadows or secretions or vascularity, you're not judging it as residue or PAS. For your standardized rating, you might make note in your report, like, I went with this, but it's definitely possible that I missed it and that actually it's aspiration, but it was like really a dark image and it was missed. Like then you add that flair to your report writing and you add those commentaries, is probably a better word, to your report writing. But for the standardized ratings, that's how you do it. That way you can stay consistent with yourself, you can stay consistent with your colleagues, but there we're trying to kind of maybe sacrifice validity just a little bit because, but the reality is we don't know what's the correct answer. So these are some examples, right? The image on the left is a classic, just like secretion bridge. I think some earlier clinicians might be like, I don't know, it looks a little white. Maybe that's just the white dye that I just gave them. And that's like good, but I think this could be reasonably judged as secretions and not white dye. Like maybe we're wrong, but I'm leaning more towards this than not. So going with this, it's within reason. Here, there's secretions, but like that's blue. So we'll include that as residue. Here, this is secretions, but this is like bright white and it looks very consistent with the bright white of what was just given. So we'll go with it. It's mixed with secretions as well, but we see the residue there. We also only want to judge the residue of what was new and similar color and consistency of what was just given, right? So if we give someone blue opaque water, we're trying to judge blue opaque water that's present. Understand though, that as the foods and liquids we eat and drink get mixed with our secretions or mixed with other residue, the color and consistency is going to change a little bit. And so, you're really, the principles that you're trying to judge what was just given and trying to disregard some of the pre-existing stuff that may be present. The thing that we're doing also is that we're not like, let's say we gave someone white water and then that swallow, we see blue opaque water subglottically that we missed prior, right? We're not going to then give this swallow an aspiration. We ideally wouldn't actually change the previous score. We would just make a comment on it, but you might go back and change your previous score, but you would just be very explicit. Like, this is PS between, it was actually observed 3 swallows later, you might do that. If things are being mixed with secretions, like you gave someone blue water and they already had a lot of frothy secretions to begin with, you're just trying to judge the amount of residue that's the liquid and that's not the secretions, right? Which might be a little hard, but we're not judging how good was their swallow of the secretions. We're judging how good was their swallow with the blue liquid that was just given. And if very little of it is remaining and it's just staining the secretions, which are frothy and not really moving anywhere, well, they did good with the liquid that was just given. It's just that they've got secretions that are left behind. So you're trying to do your best to guess how much of the stuff in the secretion bath is liquid versus secretions. And then again, same thing about pre-existing residue. Make extra reports as needed. Make extra reports if like you gave someone white water, but then the camera got gunked and you had to say swallow again, and that happened 3 times, and then we start to got views, because that might not represent how they actually were, right? And so you might do the rating, but just indicate like this was after, cued swallows due to camera obliteration. But ideally, you start to adjust how you're doing the fees, so you're reducing how often that's happening. And then the last set of rules is residue has to be visibly crossing, not just on the border, to be that lower thing, which we already kind of talked about. So if it's on the cusp between the epiglottis and vestibule, it's epiglottis. If it's on the cusp between the vestibule and vocal folds, it's vestibule. If it's on the cusp between the vocal folds and subglottis, it's vocal folds. Okay. So it's 11:22. Why don't we still just take a let's say a 7-minute break. Let's come back at 11:30. And then we'll do, I guess, a half hour of calibration practice. And then we'll break at 12 and then we'll come back at 2 o'clock. Let's do 11:30. All right. All right. Welcome back. Go for another half hour right now. I want to quickly show 2 documents before we jump into calibration practice to help with interpretation as we move forward with some of this practice. We have our normative study that we recently published, and within that study, we have a supplemental document that you can download. But essentially, this is the document, and it outlines normative data for 15 different types of swallows. This is information about, let me do this. Okay, so here we go. So this is information about the people that were included in that normative study. So we have an idea of who these norms are based off of. The outcome measures that were recorded, a little bit about how you can go about interpreting these measures, the protocol that was used, and then the actual swallowing conditions. So the idea with this is that you would use this document clinically as needed to help interpret the findings from the swallow that you've analyzed. So this works best if you're actually using these swallows. Otherwise, you're kind of drawing some inferences loosely, and that's okay as well. It's just not as direct of a comparison. So if you gave someone maybe 20 ml thin liquid, you click on this link and it would bring you down to the norms for the 20 ml thin liquid via cup. And so what we can see here is that one of these was a green opaque water, and there were 39 swallows that we're basing this off of. And one of these was a white coating water. And so again, 39 swallows that we're basing this off of. And the column on the left shows you the outcome measures. So you can see that the first one is the number of swallows that were completed for this task across these individuals. So you can see that for the green opaque water, it just so happened that around 72% of the healthy adult swallows, so 72% of these 39 swallows, were completed in a single swallow. And this is when healthy adults were asked to do it in a single swallow. And around 68% or 67% of the white coating waters were completed in a single swallow. Most people, if they didn't complete it in a single swallow, completed it in 2 swallows. And there are a couple of instances where people did 3 swallows. Okay. Here we're looking at bolus location at swallow onset. And so remember that this is, when we do this for VASES, it's indicating all structures where you see it at the onset of the swallow, not just like the worst one. So if we got visualization of the pharynx and larynx at the onset of the during the swallow phase, then we mark where we see bolus. And if we didn't see bolus anywhere, then we indicated that it was only in the oral cavity, which could be wrong. It could have actually been in the higher part of the oral pharynx that we missed, but it wasn't in the camera view. And so we can see that we indicated that this was present. It was only in the oral cavity for around 62%, 61% of the green waters and 56% of the white waters. And that it was absent, meaning there was something not in the oral cavity only, the remainder of the time. A couple of the swallows, we didn't see the onset because there was already whiteout or something else. So when it was in the oral pharynx, when it was somewhere in the pharynx, we see that it was present for 33% of the green swallows, 36% of the white swallows. Hypopharynx, only 15% of swallows. Do we see something in the hypopharynx? On the epiglottis, only around 10% of swallows. We see things on the epiglottis at the onset of the during the swallow phase. And One time we saw something enter the vestibule beforehand. One time we saw it contact the vocal folds. And then there is no present. So all of the times it was absent for the subglottis. And so this is in our healthy adults. So this is helpful, right? Because if you're seeing like bolus in the pharynx at the onset of the during the swallow phase for every single trial in your protocol, it might not be impacting physiology and function that much, but it's not normal when you compare it to healthy adults, right? You would expect it in 1 of 3 swallows, but not every swallow. So that's kind of how you can start to interpret this. For this normative study, we then have our residue ratings, and we did this. The data is openly available, so you can look at the data however you'd like. The way we organized this was we looked at when was residue present versus absent within each of these structures, and then when it was present, what was the average rating essentially. And so when hardly ever did we never see anything in the oropharynx, especially if it was white coating water, because it coated the mucosa. So there was something there. And it was present for 100% of the white coating waters, and it was present for nearly all of the green opaque waters. We saw like a speck of something at some point. When it was present in the oropharynx, I would encourage you to look at median and then the first and third quartiles and not mean, because residue ratings are typically skewed. And so we don't want to do average because averages aren't great for skewed data. So typically you look at the median. And so you'd say, okay, when residue was present, the median rating was around 2%. Hardly anything there. Probably just coating of mucosa, probably what that's entailing. Q1, that stands for the 25th percentile. Q3 is the 70th percentile. So like the average range kind of. So it was a rating of 2, but it typically ranged from 1.5% to 3%. So pretty narrow range, meaning there was hardly anything ever there and was typically just probably coating. We see the same thing with the green opaque water. Then we have the percentile rankings here. So you would say like only like 1% of adults, 1% of the healthy adult swallows had a rating of 1% or less, essentially. And then you can see it just kind of keeps going. Around 99% of adults had a rating of 15.9% or less. Meaning if you have a rating of 16%, 100% of healthy adult swallows have a rating less than that. So you have a more residue than most people, right? If you have a rating of 16%. If you have a rating of 30%, that's also like that's no healthy adult had that for a 20 ml swallow. We can, same thing with hypopharynx, epiglottis, vestibule. Now we're kind of getting at penetration, right? So we can see that residue was absent in the vestibule for about half of the white coating water swallows, and it was present for about half of the white coating water swallows. For healthy adults, 1 and 2 swallows, we typically saw something there when it became a 20 ml white coating water, right? When it was a green opaque water, it jumps down, right? And this actually confirms kind of some of our previous research that says white dyed water, we typically see things more frequently than non-white coating water. And so here, when it was 20 ml green opaque water, it was seen 25% of the time, essentially. When it was present, when there was something greater than 0% for a residue rating, we can see for the white coating water, it was just a small amount though. So yeah, it was happening in every other person for the 20 ml white coating water. But when it was present, it typically ranged from a rating of 2 to 6%, not a lot. When we go to our percentile rankings, we can see, okay, like 95th percentile is probably like a clinical cutoff that you would actually probably use. It's kind of correlates to 2 standard deviations. And so you can see like a rating of 18% or greater, that's pretty unusual. So when there was something there and it's covering around 20%, you're like, it happened. We can see it happen in healthy adults, but it's not typical at all. So we can start to kind of use that for our impressions. Subglottic residue rating for this 20 ml condition only happened once. In 1 of the 39 swallows did we see aspiration for the 20 ml liquid. And when it was present, it was only covering 3% for this swallow, right? So then the idea is that you would go for every condition and kind of correlate that. And here we have the breakdown of our PIS scores. So for the 20 ml white coating water, about 51% of those healthy adult swallows had nothing. It was a PS of 1. Otherwise, it was a PS of 3. Sometimes it was a PS of 5. And then one time, it was actually a PS of 8. PS makes sense because it was 3. It was very little. So that's how you use this document. This can be cumbersome if you're trying to use this for multiple swallows. And so I created an Excel spreadsheet, which I'll probably put on my website, but that we use here. And so this is an Excel spreadsheet where you can enter information about who did the fees, the patient's MRN, when the data service was, their age, their sex, and then this stuff gets replicated for your entire protocol. So if you said this person was like 68, you can see it duplicates, right? We can then maybe say male. We can then say maybe, what do we have here? Great, let's say Parkinson's, so on and so forth. Then you can, these rows, there we go, here to here indicate the swallow condition of what was just given, right? So in this case, it was a 5 ml green opaque water. It was thin, so this is ITSE level. So ITSE level 0 would be thin liquid. Given via a medicine cup, they were asked to do it in a single swallow. So this is the protocol that we're currently using at our institution, which is why I have it built in here. The idea is then in these yellow boxes, you indicate what the patient's sip size was or their bite size was, and then you do our residue ratings. So for watch a video clip, we could rate the number of swallows, our residue ratings, our PIS scores, and we can practice with this in just a minute. You'd come here, and then all that would be auto-generated into here with these right columns in each group being the interpretation. So this is using that supplemental document, and it's saying, oh, this is the 95th percentile, the 70th percentile, the 50th percentile. And then you have an idea of how many people have a rating of that or less when compared to healthy adults. Okay, so we can practice with that. We'll move into doing some phase interpretation with this. All right, so this is a healthy adult. However, they presented a little bit more atypical. So it's kind of an easier exam to assess, but is some mild variations in swallow function. We'll essentially repeat everything twice. First couple, normal size sip, whatever's normal for you, and then drink it like you know. I'll also say, because we only have 15 minutes, we will be doing more calibration next week as well for both fees and fluoro, but now we're gonna be able to do a lot more calibration because we won't review the rules again. Okay, I would. All right, so this is patient per volume of white thin liquid via cup, natural. So self-selected volume, patient breathe afterwards. Eventually, I'll tell you to say, but just wait. So in that example, we didn't see the onset of the during the swallow phase because there's not like post-cricoid elevation, and it's white up beforehand. This is from the velum, and then they've swallowed. So we wouldn't have been able to rate bolus location at swallow onset. Let's see the little turn thing. Okay, great. Wow. All right, so that's essentially a 5-second mark now, right? You can look at the timer down here. So I would give this a rating of 1% for the oropharynx, 1% for the hypopharynx. There's a couple of things on the epiglottis. We don't see all the epiglottis right now. Okay, so it's kind of a scattering throughout the epiglottis, but it's much more scattering than not. So I'm going to give this a rating of around like 15%. Now we have the vestibule. So again, this is a healthy adult, but again, this is one of the ones who are much more atypical. So now we say, how covered is the vestibule with residue? And so I probably tried my best to kind of consolidate all into one side or in the pedicle and think about how covered would that structure be. So I think if we like put this all on here, it's not going to cover this completely, and this is 15%, right? So I'm probably at a rating of around like maybe around Well, let's see. Let's think about this carefully. So we put this here. Maybe I'm going to put it all over here. We could probably have a complete covering or like spread across one of these. And then I would divide that in half. So I'm probably at a rating around 20% for this person, right? Yeah, do we agree with that? Do we disagree with that? So then the other thing you can think about is, can I start to now like filter on top of this? So if I thought it was a rating of 50%, then that would be, if I double this, this is completely covered. And I don't think that's the case. I think you look at it and we're like, this is a lot. This is not typical, right? But that doesn't influence the number that we give. That's our impression, and that impression is right, especially if we say it's 20%. We actually know, we just looked at it, that's atypical. But we're not trying to think about, is this really bad or not? We're just thinking about covering of mucosa. And so I think 50% is not right, because I think we can more than double this beforehand. 25%. So could we like multiply what we're seeing by 4, and would it be completely covered? There, I think we're getting very close. I think we could probably push it a little bit more though. And that's typically my approach, is because I think my instinct, and I think many of our instinct, is to be maybe a little bit more fear-based and to be like, okay, well, I don't want to go over. So then I think we need to challenge ourselves to be like, can I push it a little bit more? And then would that get us there? And I typically use that approach, and typically finding myself being like, yeah, actually, I think we could probably push it a little bit more. So this I would give a rating of around 20%. For the vestibule. And there's nothing on the vocal folds here, right? And so this would be a PAS of 3, characterized by around 20% covering of the vestibule. When did it occur? Well, we didn't see anything before the swallow. We have the during the swallow phase. There's no change in bolus location at this point. This is the after the swallow phase now. And then we see this. So the airway invasion had to have occurred during the swallow. Very possible it occurred before the swallow when we had white out beforehand, but we're going to go with the assumption that happened during the swallow. So here, PAS swallow is 3. It seemed to occur in the during the swallow phase. PAS between is 1, because there's no change in bolus flow or an attempt to eject for aspiration. With a residue rating of 1 for the oral pharynx, 1 for hypopharynx, whatever we said, 15 for the epiglottis, 20 for the vestibule, 0 vocal fold, 0 subglottis. So actually, if I pulled this up, these aren't going to align exactly, because these are slightly different conditions. But let's say I go down to this self-selected volume, which is what this was. I don't know. Let's just say this person swallowed 25.0 milliliters. They did it in 1 swallow. You can give it a rating of 15. We'll say 20, 0, 0, 1, 3, 1. So that's indicating when this happened. And then 1 between. So then this calculates this. And then if we go back to this, and if we just wanted to stop here, then we could see that no one has less than 1 swallow, which makes sense because they swallowed. Most people have a rating of slightly higher than this, right? A little bit more than 1. Hypopharynx, most people have a rating of slightly higher than this. Vestibule, 98.6% of people have a vestibule rating less than this. So this is not typical. They're healthy though, so it's just, they're not a typical healthy adult. Nothing for the vocal folds or subglottis. They had a PS of 3. 78% of healthy adult swallows have a rating of 3 or less. Okay, so that's how we would use this. We can also see that for their self-selected volume sip size. Oh, I should have done white. I should have done it under white, but oh well. They have a relatively normal sip size for 25 milliliters, right? Okay, let's keep going. Let me find the next one. So now this is actually green. Golper, yep, that's good, that's good. Now whenever you're ready, we'll do the same thing. This is gonna be patient per volume of green and liquid via cup, natural. Same thing, 1 normal size sip, whatever is normal for you. The self-selected volume, green opaque water, natural. 2 swallows is what we just saw. Now we're looking at our 5-second counter. Oh, okay, right, so let's go back to that again. Let's do our temporal boundaries. They go to swallow. Again, here we didn't see the onset of the during the swallow phase. They go to swallow, and here the postcrical region just returned to its lowest resting position. We're at 22 seconds. So if we get to 27 seconds, then we know we're at the offset of the after the swallow phase. Oh, they swallowed again. So now I have to reset our timer. So 25 seconds. So if we get to 30 seconds, we can start our ratings. Right. So now this is what we're trying to capture for the offset of the after the swallow phase. Let's see. So then we have a rating of maybe 1% for the green opaque water. Do I see anything in? Yeah, so we see like a thing there. So 1% for the hypopharynx. Do we see anything in the epiglottis? I don't visibly see green. And then I don't see anything in the vestibule, vocal folds, or subglottis. Okay, so now let me come back up here. So let's see. We'll call this 27.0. Why not? Here they did 2 swallows. So actually, I'm going to make this correct. That was the white one. So this is green right now. So now we'll have the accurate auto interpretation. So here they did 2 swallows. We said 1, 1. We said 0. Vestibule, we had 0, 0, 0. And then these are PSs of 1s. Okay. So now, and I would not be going back and forth like this. I'm just showing this so you can actually see it. So now we see 2 swallows. Okay. Actually, yeah. So 2 swallows. Most people are doing it in 1 to 2 swallows. That's what that's telling us, right? Oropharyngeal residue rating, relatively normal, and no one has a rating less than 1 for the PS because that's not possible. So they are normal so far. All right, let's look at the next one. So now let's move on to some smaller stuff. Last natural, we're going to give the earring a mouth, put it all in your mouth, and just do 1 swallow as best as you can. Try not to do extra swallows. If you have to, that's totally okay, but try to wait at least 5 seconds before giving us that extra swallow. And then just like you were doing before, try to avoid any sort of talking, just breathe afterwards, and then eventually I'll have you say, so you heard that instruction. So you on your own. I'm just kind of reminding them. 5 ml of white liquid via cup, single swallow. All right, did we see the onset during the swallow phase? Not sure we did. Looks like no. So we're at 30 seconds. All right, so here we had the 5 seconds. There was inactivity. They didn't talk. We didn't advance the scope. So now this is the offset of the after the swallow phase. This is what we're trying to capture for our residue ratings. So again, I would give it a rating of 1 for the oral pharynx, 1 for the hypopharynx. We're seeing a little bit there, but I mean, we can get a lot more of 20 of those in there before we're on the verge of overflowing. We're seeing a little bit of stuff on the epiglottis. So, I mean, we can get a lot more than 10 of these in there. So I'm probably at like 4% for the epiglottis. And then now it's like, I see that little guy there. I see this little guy here. So now it's like really understanding our boundary. This I'm not concerned about. This is on top of the epiglottic folds, but it's not crossing that boundary. So then we're going to, okay, great. So now we got a better view, thank goodness. And so now we know that they had residue in the airway, but we can see it's very little. This I think could be reasonably judged as secretion, so I'm not going to include that. And this occurred presumably during the swallow. So let's pull this over here. Oops. This is 5 ml green opaque water, or white pudding water. Great. So they did this in 1 swallow. We said 1, 1, 4, or 5. That's fine. Whatever. It doesn't really matter. We'll give it a rating. I don't know, 2.5. Nothing. Yes, of 1, 3, 1, 1. Great. And now we can see. 1 swallows, normal. Like when this number starts to become like 90, 95, then we're like, this is getting really weird. When it's like 75 to 95, we're like, this is a little weird. When it's 95 and above for the interpretation, then you're like, this is really atypical. So you can see this is normal. We can see they had stuff in the vestibule, but like when people have stuff in the vestibule, this is like what they're getting. Like half the people get this value or less. So this is pretty normal. PAS of 3, around 78% of healthy adult swallows have a rating of PAS of 3 or less, is how you would interpret that. So great. Questions about these ratings so far? These ones are pretty straightforward. I think there are other different ones in here. Five ml of green from could be a cup, single swallow. Same thing whenever you're ready. I think there's an aspiration in one of these, so I just want to see if I can try to get to that. Okay, so there, I think we saw onset of it during the swallow phase. Yeah, so here we're going to judge both location at swallow onset and onset of it during the swallow phase. So my eye is kind of in this region here. This is not lifting up right now. The tongue is retracting, but this is not lifting up yet. I'm not even getting distracted. I'm not even looking at the bolus right now, so don't get in that trap either. So I'm moving forward, and here we're starting to get like a blurring of structures, and it seems like it's uninterrupted and leading to the swallow. So I would say like this right here, especially because we see that that is getting blurred, the postcricoid region right here. So in this example, I would probably use this frame. Ideally, we would have gotten a better view of the postcricoid region as the onset of the during the swallow phase. And we can see that bolus is in the oropharynx. Hard to know if that's in the and in the hypopharynx. So I would say oropharynx, hypopharynx for bolus location at swallow onset. They do one swallow. I'm looking at the counter. Does it get to 21? All right, it's been 5 seconds. So they did one swallow. And we see a little bit of something there. We see a little bit of something there. So a residue rating of 1 and 1 for the oral and hypopharynx. All right, and now we're seeing stuff within the laryngeal vestibule, right? We're seeing this stuff here, this stuff here, this stuff here. We can see through the mucosa, but we see that still kind of covering some of that. I think if we put this all like on the petiole, it's not going to cover even half the petiole, and that would be then 7%. So we're at a rating of around like 4% again for the vestibule. Hard to know if that is something I want to be more confident rather than less confident. So it almost looks like it's maybe more the ventricle. It might be residue, but I could reasonably judge it as shadow or something, or veins too. So I'm not going to go with it being residue. I'm going to say it's 0 for the vocal folds. But again, maybe we're wrong. All right, let's rush through a couple more swallows. I'm just going to scroll for. Oh, this looks like. Yep. Okay, let's just watch this one and then we'll be done. Oh, this is 10 ml of white liquid via cup, single swallow. All in your mouth, one swallow. Don't see also the during the swallow phase. And cough. Okay, so he vocalized, saying he was gonna cough, so this might be a conception, right? Because technically vocalization would have stopped the boundary, but he said he needed to cough, and he knew this was in the context of research, so I think that would be another thing I'd like to do too for your pheses is tell them to feel free to cough or throat clear as needed. So they go to do this. And we're judging before this point, right? So in terms of residue, but then we would say that he made an attempt to eject. So our residue rating, this would be a vocalization, the coughing and everything. So oral pharynx would be a residue rating of 1. Hypopharynx would be a residue rating of 1. That's a really good picture of the subglottis. We can rate this right now. So we can see this is all on the ridge. It looks like that stuff is there, but we can like make sure that's really good. We can put it here. There's some subglottic shelf that we're not seeing, but not a lot. And I think what we are seeing would be completely covered with anything in the subglottis. So I'm going to give this a rating around 18% or 85%, because I think we're not seeing around 15% of the subglottic shelf, and everything that we are seeing is covered up to that ridge. So he coughed. It's a very high residue rating. in the subglottis. Still haven't gotten a great view of the epiglottis or vestibule. We did get with the vocal folds. We should judge that quickly. And so I'm going a little bit later into the swallow for that rating of the vestibule. This is a good view of the vocal folds. It looks like it's kind of completely spread across the superior surface, but it looks like it's not maybe 100% of a blanket. It's hard to know, is it covering it completely or is it just sparse? So I'm inclined to kind of be somewhere between like 80 and 100% for the vocal folds as well. And I'll probably give it like a 90%. We can see the vestibule though, from what we are currently seeing, it's pretty much spread across half of the petiole, which would be 7%, but then cut that in half, we're at like 3%, but then I feel like we still get a little bit more later. So I'm probably gonna give this a rating around like 6% for the vestibule or something. We have to get going because the conference room, but that's how we go about rating it. And so that's kind of our sense. And I would say here, it was a PAS of 7 that occurred during the swallow. So the PAS swallow was 7, and then PAS of 1 between. So, all right. So we're gonna get going. I don't know if we have any other questions before we get going. Okay. All right. So hopefully this helps, and we'll do some more calibration practice on fees next week. All right.